So we're going to talk about pharmaceuticals and pharmacology at the 1,000-foot level, and then we are going to get down to the micronic level about pharmacology and specific medications. So some of this comes back from the lecture that I prepared way back. I don't know. I think Dr. Sokel still used my pharmacology lecture in Rehab 1, but I honestly can't tell you. Because I don't talk to her that much. So as far as that goes, it's her class. We're going to talk about the specific kind of definitions you need to understand for pharmacology. And then we're going to get down to the weeds when everyone starts freaking out about pharmacology, because this is probably the #1 topic I get people freaking out about right before the board, literally like a week and a half before the boards. This is the one that suddenly everyone's like, oh my God, I don't remember the difference between a muscle relaxer and an antispastic medication. Okay. Pharmacology is not as much of your boards as it could be, right? We're not PT, so we don't have to specifically know diagnosing and stuff like that with pharmacology, but we do need to know interactions and stuff. So key terms for review for this, just kind of that we can go back and hit this again. Pharmacology is the study of drugs itself. So when they're talking about pharmacology, it's literally looking at the drug itself. Pharmacokinetics is usually more of what we talk about. Even though we don't call it pharmacokinetics, what we talk about is pharmacokinetics. That's the absorption, distribution, metabolism, and excretion of drugs, right? That's if I take a Tylenol right now, how long does it take to get absorbed? How long does it take to hit wherever my pain is? What happens as it gets metabolized in my body? And then how do I get rid of it? Right? That's kind of, even though we don't talk about that, that's what we talk about when we talk about drugs. The pharmacodynamics are how that drug affects the body, both in the biochemical level and the physical level, right? Some of the drugs are going to have a very physical effect. A muscle relaxer is going to have a very physical effect on your body. At the same time, it has a biochemical effect on your neurological system. So they have a little bit of both. We have to talk about that. A pharmaceutic topic is when we talk about how the drug is broken down and used by the body. That talks about where does it get, does it get dissolved and broken down in the stomach? Does it get broken down in the small intestine, the large intestine? Where does it go from there? Is it a liver saturated drug? Is it a kidney saturated drug? Where does it get stored? Does it get stored in the adipose, right? All of those drugs kind of come along the way. And when we talk about pharmacology, we also have to include illicit pharmacology as well, right? Typically, when you hear pharmacology, we're thinking, stuff that the doctor gives us or stuff that we pick up at Walgreens, right? Or wherever else, whatever other pharmacy, Rite Aid. Is there any Rite Aids anymore? I don't even know. I think they're back in Pennsylvania, but I don't even know if there are any Rite Aids. Yeah. I know there are in Pennsylvania because my sister works for them. But there's not out here anymore. Or what's the other one? Eckerd used to be one. I don't think there's any Eckerds anymore. Yeah, they're right. There are some in Arizona and Cali, right? I think Eckerd is completely gone. I think that one died out a long time ago. I think that was absorbed by the red one. What's the red one? CVS. So the pharmacotherapeutics are when we use drugs to treat disease. Like back at the beginning of COVID, when we had this huge, brilliant idea to use hydroxychloroquine to treat COVID. Didn't work. But we still tried it, right? And right now, out in research labs all over, they're trying a bunch of different drugs. They may try drugs that were not even meant for treating diseases to try to treat a disease to see if there's an effect on it. Pharmacoeconomics is one of the things that a lot of you probably do. If any of you take any regular medications, I don't know, and I hope that you guys do this, but compare one drug price to another, as well as the efficacy based on that price. I don't know how much you guys realize this, but your your prescriptions, there's a better term for it. Your prescriptions that you get vary greatly pharmacy to pharmacy, like majorly. over Christmas, I was down in Tucson and I got some bad food. I don't remember where I think I ate at Blake's Lottaburger down there. And I got some really bad food poisoning. And so I did a telehealth visit with the doc, and the doc ordered me some anti-nausea meds. And it was a generic. So I'm thinking, okay, generic, and it was 15 pills, not going to be that much. I took it to the normal Walgreens. I didn't really think of checking, and I should have done this. But Walgreens is like, that'll be $83.50. 15 pills, $83.50 for a generic? Yeah, give me that prescription back. Nope, sorry. And so like I was like, okay, well then I used the GoodRx app that I've never used, and I'm like, oh, well it's $83.50 here. It's $4.50 over at Fry's. I took the prescription over to Fry's, filled it at Fry's, and paid $5 for 15 pills. That's literally not, and that's no joke. That's a $70 variation in price based upon where you get your prescription filled. So it really does behoove you guys, if you take medications, or if your maybe family members take medications, especially heart medications, depression meds as well, or any type of psychoreactive drug, because those are really ripe for, I wouldn't say abuse isn't the word, but just price gouging. The one heart med that they had me on back when I was taking heart meds was like $140 at Walgreens and $23 at Costco. And so the pharmaconomics can really come in play, right? Especially if you're on a budget. I will say that if you are a member of Costco, or what's the other one? Sam's. They usually have some of the best prices for getting your pharmacy medications. The only downside to them is they have weird hours sometimes. Pharmacogenomics is how genes affect the patient's response to drugs. With my blood that I have from my genetics, drugs are going to affect me differently than how they affect Jessie, because she's going to have a little bit different genetic makeup than I am, right? And then it's going to affect her different than it'll affect Jaira. So it's going to affect everyone a little differently based upon their genome. This is probably my favorite one here, is psychopharmacology. This is actually one I really wanted to kind of get a degree in, because I thought it would be fun. Yeah, I get degrees for fun. What is wrong with me? This is how the medications affect the mental state. Have you guys ever seen a patient that's taken their medications and it's affected their mental state? Have you ever seen something where the patient takes the medication, they're a totally different person? Yeah. I mean, I can tell you a Mr. McKeever funny story. Back when I got my neck implant, or not implants, yeah, got my neck implants done. I got my fusion done. I couldn't sleep, so they gave me Ambien. And I had never taken Ambien before. And so I took it, and I didn't read the thing that says, if you take Ambien, go directly to bed. Do not pass go. Do not collect $200. Go directly to bed. And so I decided I was going to sit up and watch some TV. And man, was that an experience. It was like I was in the TV watching it. And then about 9 hours later, I woke up and I was standing in my hallway leaning against the wall. That's evidently how I fell asleep. I decided at some point to get up and go to bed. I fell asleep standing against the wall. That's not a normal response to a human being. It's actually, yeah. I don't know how much you guys know about Ambien, but man, if you try to stay awake, don't try to stay awake on Ambien. Just take it and go to bed. You'll see some really wild things. Just saying. And that's not a challenge. Other terms here, a dose. A dose is how much you're supposed to take at one time. So for example, Tylenol extra strength, you're supposed to take maybe 2 of them every 4 to 6 hours, I think is what it says on the label, right? That's a dose. A dosage is how much you're supposed to be received over a specific condition. So let's say that you have the flu and they give you an antiviral. The antiviral that you take every day is your dose. The total amount in your prescription is your dosage. Dosage gets a lot harder to manage when you're talking about pain medications like Tylenol and Advil, because, you know, I know people that take 5 to 10 Advils a day just because they think it keeps them going and probably not really helping that much. These three terms here, if you get none of the other terms, these three terms here are very important. You must know them. The first term is misfeasance. Misfeasance is the administration of the wrong drug or dose to a patient, and the patient suffers harm or death. So what could this mean? Well, I'm going to use my family as an example. My mom, back when she started getting really sick and almost before she passed, they thought she had a virus, a general virus, or not virus, a bacterial infection. They thought she had bacterial meningitis. So they gave her a bolus of penicillin. And a bolus we'll talk about being a loading dose. But they ignored on her chart that it said patient is allergic to penicillin. And so she actually ended up having a seizure from taking penicillin because she was that allergic to it. That would be misfeasance, because they gave her a drug that she wasn't supposed to get. Some of you may have allergies to certain drugs. I know people that have allergies to Benadryl, which is, to me, really amusing. You have an allergy to Benadryl. Okay, no one else finds that as amusing as I do. I find that amazingly funny. But misfeasance, the use of the wrong drug or dose. So what else could that be? Yeah, isn't it ironic, don't you think? The other thing that could be is the nurse looks, so misfeasance could have happened to me when I first broke my neck, because I go into the hospital telling them I'm in pain. The nurse comes over with 50 milliliters or 50 ml of morphine for me. And I looked at the syringe as she's getting ready to put it in my IV, and I said, whoa, 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 wait, what is that? And she goes, what's your dose of morphine? Like, that's a lot of morphine. How did you calculate it? And she's like, well, you're 235 kilograms. Yeah, and I was like, yeesh, right? Yeah, so she read my chart, and either that or somebody put in my chart that I was 235 kilograms, which would put me close to what weight? In American terms, about 500 pounds. I don't think, I mean, I know I got a little bit of cushion here, but I don't think I have 500 pounds of cushion. Right? So that dosage literally could have killed me. That would have been a misfeasance. Malfeasance is administration of the correct drug to a patient, and the patient dies usually via the wrong route. So can anyone think of an example for this where they say that they give the right drug to the patient, but the patient suffers a harm or dies because it was given in the wrong route? Yeah, right. Yeah. So they, instead of injecting it into the IV, they inject it in the NG tube. Great. And that literally can happen. If the patient takes too much or the nurse gives them too much. If the patient takes too much, there's not a feasance here. So when you see feasance, something bad has happened. Feasances are legal terms. If the patient takes too much, it's an overdose, right? That's a voluntary, or not, well, I guess it could be voluntary, right? Could be involuntary if you really looked at it hard enough. But that would be an overdose. The feasances are legal terms that give people legal recourse if something happens, right? These are lawsuit terms, right? Let's just face it, they're lawsuit terms, but you have to know them. Non-feasance, to me, is the most egregious of the feasances. Nonfeasance is the lack of administration of a drug that leads to a patient's harm or death. So this would be a nurse, doctor, whatever, that doesn't give a patient medication because reasons, right? Could be financial. They're in the ER, they need a drug, and they know they don't have the finance, they don't have the insurance for it, so the doctor decides not to give it to them, right? Why would a nurse maybe hold back medications? Let's just face it. What's the mean reason they might hold back medications? Forgot. Okay, good. That's an easy one. Fighting. Yeah. Right. Well, John, you were such a pain in the butt to me. I'm not going to give you your medications. And then John either has harm or death because she didn't give him his medication. Right. I've seen it with antipsychotics. And this is a sad part where patients need the antipsychotics not to have kind of that break with reality. And the nurse in the psych ward holds back their medication because the patient was mean to them. And so then the patient doesn't get their antipsychotic and they do something stupid, right? I've seen a patient literally bash his head into a window until was unconscious because they're trying to stop the voices in their head. Right. But they would have been fine had they gotten their antipsychotics. But that was, that's a lawsuit waiting to happen. Right. That is literally any of these three could be a lawsuit waiting to happen. Is there a chance looking at physical therapy, if we consider physical therapy a prescription, patient refusal doesn't count as nonfeasance? You're right. Unless, Javen, unless it's a drug that the nurse knows the patient needs to survive. At that point, the patient's refusal may be null and void. Right? Yeah. So that's the key thing. Like if they know that if this patient doesn't get this drug, they're going to suffer harmful effects, the nurse may still just give the drug. Right? There are certain rules on that, and I don't know all the rules on administering drugs, so please don't think I'm a god at this yet. But that would not necessarily be a patient refusal is not necessarily a feasance. So let's say we're going to say physical therapy is a prescription, right? So technically we could consider that a drug, couldn't we? Could we suffer nonfeasance by not treating a patient? So the lack of administration of a drug that leads to a patient's harm or death. Yeah. Right? Oh God, not, oh, he's back in the hospital again. Oh God. Well, you know what? I'm going to go see everybody else. And maybe if I get to it at the end of the day, I'll treat him. Right. And then that patient gets up and falls. Technically, we would be liable at that point. So we have to be thinking about that, this isn't only nursing and doctors that could do this. Technically, we could play along with this. I mean, even looking at the, theoretically, malfeasance can come into play as well, right? Administration of the correct drug. So we give them physical therapy, but the patient suffers an adverse event to it. So we're going to go see them for physical therapy. We don't check for contraindications. And so we start doing range of motion activities in the patient. The patient has a fracture. That's new. Technically, that's malfeasance on our part. Right? So that's always good to go in and say, and how many of you, I'm going to open this question up. How many of you guys saw your existing PTs or PTAs when you were out in the field actually ask for contraindications? Did any? Okay, so Kelly did see it. Okay, good. That's better than I expected. Look, I'm already 100% better than I normally get. So maybe you guys going out in the field and asking contraindications is finally kicked in, because I can tell you, when I was in the field, when I was in the field full time, almost no one asked about contraindications. They just treated the patient. So I'm happy to hear that. Actually, that means that we're looking at this more on the malfeasance line, going, okay, we got to protect ourselves and protect our patient. Round of applause for that. Round of applause. I'm happy for that. Blood flow restriction. Okay. Hey, look, at least it's something, Erica. I'll take it. That's better than nothing. But I mean, I know you guys, because I've heard I've actually talked to CIs before, and they're like, why do your students ask about contraindications for ultrasound? I mean, if we prescribe the ultrasound, then they shouldn't have to ask that. No, you should still, right? And you can make it, and I make it just absolute, like when we talked about with your comps, I make it the absolute silliest thing in the entire world. I kind of make it a joke to the patient, you know? Is there anything new I need to know about? Have aliens abducted you? Did you get any new fractures? You know, is there anything changing with your blood pressure, your medications that I need to know about? And we get a good chuckle about did the aliens abduct you? Because, you know, we are in Nevada and we have Alien Highway north of us. But it's still a way, right? You sneak those into a conversation starter, exactly. And it kind of breaks the ice a little bit too, right? Especially if you have those patients that you're walking in, you're like, oh boy, this is going to be fun. I've asked, have they participated in any Broadway shows recently, stuff like that, just to make it kind of fun when I'm talking to them. I get away with a lot of stuff now that I think about it. So the terminology of pharmaceuticals, the chemical name we almost never use. The chemical name here, we're looking at N-acetyl-para-aminophyl. The chemical name is that name for the drug that, it basically looks at what molecules make it up, right? The generic name is the kind of common name that we use, right? The generic name is just what it is. In this case, the N-acetyl-para-aminophyl is paracetamol, acetaminophen, or APAP, right? The brand name is a trademark name by a company. So in this case, we're talking Tylenol, right? But have we kind of made Tylenol ubiquitous with pain medication? Yeah, right? I mean, some people still say Advil or something like that, but for the most part, if you're getting something to take go take a Tylenol. And you may be taking Advil, but it's just one of those things that just shows you how much brand recognition, right? It's kind of neat. The drug class is what the drug is used for. So in the case of Tylenol, is an analgesic non-NSAID. So those are the type of breakdowns. The number one question I get here is, Mr. McKeever, if I get a question on my boards, is it going to be a brand name? Is it going to be a generic name? Or is it going to be a chemical name? I can tell you it's not going to be a chemical name. So you don't have to worry about that. You don't have to memorize chemical names. Some of your questions will be on a generic name. Some of your questions may be on a brand name. The reason for that is if the drug is still under patent by a company, trying to think of one, Ubrelvy, there's a new drug that's out there. Typically in that case, because it's still under patent, any questions we ask on it has to be based upon the patent name. Once it is out of patent status and there can be generics available, then we call it by the generic name. So take, for example, Antivert, which we talked about a little bit, right? About 10 years ago, if you had a question on your boards about Antivert, it would be listed as Antivert because that was the brand name, right? Now, if you get a question on it, it will be listed as Meclizine because Meclizine is the generic term for it. So, and we'll talk about that when we talk about heart meds and stuff like that. So you're not going to have to necessarily know the names. You may have to know the class. And I'll give you some tricks for memorizing the classes as well. So don't totally freak out about that. There are some tricks to it. And then we talk about either prescribed or over the counter, right? If it's prescribed, we got to have a doctor's note. It's the easiest way to think about it. If it's over the counter, you can get it without a prescription. Can some over-the-counter drugs still be prescribed? Yeah. The one I think of here in physical therapy is ibuprofen. Because a lot of times doctors will give 800 milligram ibuprofen. And so you can go get that filled at the pharmacy, right? And you can pay the pharmacy price for it, but what else could you do? You could just as well take the over-the-counter, right? Take 4 regular ibuprofen, because that's 800 milligrams. People tend to want to get the one that's from the pharmacy because it usually has something on the coating on it that helps your stomach absorb it, not absorb it, but not get as upset, right? 800 milligrams of ibuprofen tends to upset the belly quite a bit, especially if you didn't eat. And then we have this term called compounding. And we do have a couple of these pharmacies in town. There's actually one right down from the school that are custom compound pharmacies. What they do is they will custom mix medications for a patient's need. So maybe a patient needs an ibuprofen, instead of having a Tylenol, a pain med where it's your narcotic plus Tylenol, they need a pain med where it's narcotic plus Advil or ibuprofen. Those aren't commonly drugs that are out there. Maybe the patient has an allergic reaction to Tylenol. So they can take that script to a compounding pharmacy, and the compounding pharmacy will make custom medications where it's the appropriate level of opioid plus Advil. And they can make all kinds of stuff. And a lot of compounding pharmacies they're usually boutique type pharmacies, I'll be honest, because a lot of people that I see that go to them go to compounding pharmacies because they don't want all the fillers of the over-the-counter or the medications given by pharmacies. I don't want those fillers in my drugs. Whatever, sure. Administration routes. These are the fun ones. How do we take it? We can take it orally. Boom. You can take it rectally or vaginally. You can inject it. You can topical it, meaning lay it on the skin. You can inhale or make it respiratory. And this would include, in the case of right now, medicinal marijuana, taking it in by smoking, right? Which of those do you think is the fastest delivery route for the medication? Yeah, injection is the fastest. Then comes rectal or vaginal, right? And it makes sense because if you inject it, where are you injecting it into? The bloodstream. Yeah, right. So it's going to get around a lot faster that way. Rectal still takes a little bit of travel time to get absorbed. And exactly, just don't say anything in butt chugs. Exactly. That's one thing we're finding out right now is a lot of teens nowadays seem to think that it's fun to take alcohol rectally. The sad part about that, and they don't know, is it's a lot easier to get alcohol poisoning that way. Why? So that just begs the question, why does taking a drug rectally or vaginally work better? Why does drinking that way get you drunk faster? I still don't understand it. Yeah, well, more importantly, it goes into the large intestine, and the large intestine have a large amount of receptors in it. So they can suck the stuff right off of it, right? It doesn't have to get processed through the GI like Justin said, exactly. Doesn't get mixed with hydrochloric acid and broken down as much. I don't remember if I told you guys this before, but I saw down in Henderson, I don't remember where I wish I could remember the name of the place. There's a place that does coffee colonics to get you going in the day, where you can go in and get your coffee delivered rectally. So you want that instant pick me up in the morning, you go stop by for 15 minutes, they deliver your coffee rectally, and off you go. I mean, I'm all for the old fashioned just drinking my coffee. I'm just going to say it right off the bat. Which one of those do you think is the slowest method of delivery typically? Yeah, topical candy. Now then that begs the question, why do fentanyl patches work so well? Well, because they have specific medications that cause it to get absorbed quickly. That's really why fentanyl patches work so well. It has nothing to do with the fact that it's a topical. It's just the fact that they have medication that force it to get absorbed more, right? So orally, thinking of medication, we can think Tylenol, right? Rectally or vaginally, your suppositories and stuff like that to help with either constipation or diarrhea. Injection, I think of the medications you get in the hospital. Topical, the first thing I think of is fentanyl for that, because that, or it could also be those salon pass patches, right? Those are technically a topical medication. The ones that have, I think, lidocaine in them and stuff like that. In inhalation, you know, you would think that being in Las Vegas, I would think inhalation, I would think immediately to medical marijuana, but I think more along the lines of asthmatics, right? The drugs that help you with breathing. Those are more the inhalation ones I think of. So the metabolism, this is a thing you do need to understand, which is half-life, right? Which was a great video game, by the way. So half-life talks about how the body metabolizes drugs. A medicinal half-life is a time that takes a drug concentration or amount of drug in the body to be reduced by 50%. It is a video game, right? Yeah. But guess what half-life the video game is based off of? Half-life, right? Nuclear half-life, but not medicinal half-life, right? So this would be example. So I'm taking a drug right now. I'm taking caffeine into my body. At some point after I finish all my coffee, if I don't drink any more caffeine, there's a certain amount of time where that drug will be reduced by 50% in my bloodstream. Right? That would be the half-life. So after one half-life, there's about 50% of the drugs in your body. After two half-lives, we're now at 25%, right? It takes a drug to get to 4 half-lives before the drug is considered pharmacologically negligible. So, such as opiates. Opiates are a great kind of example here. Opiates, their peak time is about 45 minutes after taking them, right? Their half-life is about 2 hours. So if their half-life is 2 hours, what would be the second half-life? Yeah, 4, right? It would be double the original half-life. So at 4 hours, now the drug is down to 25%, which is why if you get a opioid, what do you think how often do you think you're supposed to take it? Every 4 to 6 hours, right? Because then it's either 25 or 12.5%. That means they're trying to get you set up so that you get to the next half-life before it all wears off. Does that make sense? It's to keep that constant loaded dose going. So let me just so that I can make sure that's clear, I'm just gonna write a little bit here, right? So let's get my little color pen. So we'll come down here and we'll steal this little area here. So looking at, oh God, that was bad writing. What was that, Mr. McKeever? Oh, I can't find my cursor. So an opioid. Opioid. So if you see it listed as a T1/2 equals 2 hours. And we know that we have to get to 6.5%, right? Or 4 half-lives before we're at a negligible amount. That means at 4 hours, we're now at 2 half-lives. What about at 6 hours? What am I at? How many half-lives am I at 6 hours for 2 more hours? Not quite 4 yet, because I just added another 2 hours. So now I'm at 3 half-lives, right? And then at 8 hours, now I'm at 4 half-lives. Does everyone understand the math there? If you don't, we can do another example. I just want to make sure that you kind of understand the math. So this means with an opiate, and I'm using a specific opiate, I'm not going to say which one it is, but I'm using a very specific opiate. It would take 8 hours until the drug would be considered pharmacologically negligible. So there's an important thing to think about with that. That also means it would take 8 hours until you're technically able to do what? Drive. Because anytime before that, technically you would be driving on a controlled substance. Does that make sense? Yeah, I never thought about that, right? So I'm just going to do one more example since we're kind of quiet here. So let's talk Tylenol. So Tylenol's half-life is about 1.5 hours. So that's for one half-life. In order to get to 2 half-lives, I'm going to double my amount of time. So that would be how long? 3. Good. And you'll see something magical here, right? So that means to get to 3 half-lives, I'm now going to be how long? I know math. Good, 4.5. Renee's on it. She's like, I want to get out of this math stuff. And again, if you look at that, right, and then to get to 4 half-lives where we're at negligible, we're at 6 hours. And do you see something magical about that time frame? When you take Tylenol, what do they tell you? Every 4 to 6 hours. It's almost like there's a madness behind it, right? Or a method behind the madness. Does that make sense, at least on the rudimentary level? Okay, thank you. Renee says yes, so okay, good. You may think that you don't have to know this, and here's the deal. You're not going to get a question that asks you to calculate half-life. So everyone take a deep breath, right? But they may give you a half-life and say that the drug has a half-life of 4 hours. Let's talk muscle relaxers. Has a half-life of about 3 hours. That means you'll want to see the patient within that 3-hour time frame of them getting the drug, right? Because that's when the drug is going to kind of be at its peak efficiency, is in that first half-life. But something like a sedative, are you going to want to see somebody in a peak period of the sedative? You know, sedatives make you go sleepy. Yeah, no, right? Give them Ambien. It's not time to go do physical therapy. I mean, you could be interesting. So how do we get rid of drugs? Well, we have a couple different ways to get rid of drugs. Kidneys, liver are common ways. The liver processes a lot of our drugs, right? And that's why things can really mess up your liver pretty bad, especially like Tylenol. It's not processed the kidneys. It's usually or liver. It's usually processed the kidneys. We do excrete it through feces. You do breathe out drugs. Poor liver. Exactly. And thinking about that, we know that we breathe out drugs because sometimes if you get pulled over, what does the cop give you? A breathalyzer, where he has you breathe into the thing, and that is pretty accurate as far as tracking what the blood level is. If they get a high reading on the breathalyzer, for the most part, you probably have a high blood content, unless of course you've eaten something that has high alcohol content. But then it also gets stored in the fat, the muscle, the bone, all of that stores medication, right? Especially if it's not one that's easily excreted. I think of cocaine as a great example. There was a story back in the late 80s of a Wall Street guy who was a heavy Coke user. Not Coke like this Coke, not this Coke, like bad Coke. And he had lived a fairly unhealthy lifestyle, but used cocaine heavily, but got really, really large. Like the guy was about 400 pounds or something like that, because there's a whole medical journal article written about this. And so he decided to go on a diet, and he had stopped using cocaine at that point. And when he went on the diet, he ended up dying of a cocaine overdose, even though he wasn't using cocaine anymore. And why was that? Because he started losing weight, and the cocaine that was stored in his adipose suddenly rushed his system. Yeah, it's kind of crazy that we can do that type of stuff, right? We store heavy metals in our bones. Some drugs get stored in our muscles, so all that can happen. So I talked briefly about this. I mentioned this while we're talking about the half-life. We have these two different terms. We have a peak and a trough, right? The peak is when the drug's at its best. The trough is when it's at its lowest function, right? Usually when we talk about trough levels of drugs, it's usually about the time we start giving them the next dose, right? But in the case of something like a sedative, like I said, that peak level is going to be where we don't see them for physical therapy. We want to hit them in the trough level, because that way they're pseudo awake. And if you guys have ever taken a sedative, there's really not a point that you're ever fully awake while you're on a prescription sedative. It keeps you kind of foggy the whole time. So that means if a patient's on an opioid pain reliever, when would we want to see them? During the peak level or the trough level? Yeah, peak. Because at that point, the pain meds are most in their body and relieving pain. Do you think there'd ever be a time where we might want to see them in the trough level? Yeah, right? What if we want to see how they do without their medications? Right? I'm thinking now along the lines of patients that are like Parkinson's, right? When they're taking L-Dopa. We normally want to see them at that peak level because that's when the L-Dopa is kicked in the most. But we may also want to see them every now and then at the trough level so we can see what their functional ability is when they don't have their medications, because that can tell us a lot about patients. Some of you may have family members that are on antidepressants or, psychoreactive drugs, stuff like that. You can tell when they hit their peak levels and when they're kind of tapering off their drugs based upon their mood, right? Sometimes when they're up here, they're okay. And then you can start seeing that kind of tapering off and being not so nice anymore. So side effects of drugs. Side effects are physiological effects not related to the drug, right? All drugs, doesn't matter what the drug is, have side effects or undesirable side effects. This is when you get the drug commercial for whatever it is, and at the very end of the commercial, they're like, side effects may include blah, 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 and death. I love it when they add that, and death. So take, for example, Benadryl. Benadryl's main effect is antihistamine. One of the side effects of Benadryl is sleepy time. Right? Benadryl makes certain people sleepy. Now, there's also about 1 or 2% of the population, when you take Benadryl, it wires you. So there is that too. That would be a different side effect. So we have side effects that are okay. So sleepy time may be an okay side effect for people, right? But we also have adverse reactions or severe types of side effects. They're usually unwanted and would not be normal at recommended doses. Adverse reactions are always undesirable. They always have to be reported and documented because they represent variances in the planned therapy. If there are adverse reactions, they should be reported to the FDA by the manufacturer. So the vaccine that we're all getting, does the vaccine have side effects? Does it have adverse reactions? Yeah. For certain people, there's going to be an adverse reaction for the vaccine, right? Not everybody. So, for example, when I got my second dose, one of the adverse reactions I had because it kicked up my IgG levels was I was sore, achy, grumpy, and had a headache. Those are side effects. Now, I would call them adverse reactions because I wasn't happy about them, but I lived through them. There are some patients that took it that it gave them Bell's palsy. Now, I'm going to preface this. The shot did not give them Bell's palsy. The shot kicked up an existing herpes infection that gave them Bell's palsy. Does that make sense? Herpes was just hanging out back in the back room and all of a sudden was called out the party, right? Just because we got that and the IgG kicked up, so herpes said, hey, it must be time for me to come out and play. And they got Bell's palsy off of it. Similar thing of right now, there are some adverse reactions where a patient may get Guillain-Barré syndrome from getting a vaccine. Here's a hint. You can get Guillain-Barré from almost every vaccine. Well, why is that? What do you think the latent infection that kicks up Guillain-Barré is? Typically. Our buddy herpes. Right? And we know that if I was to take a poll right now, if I started a poll and asked how many of you guys have herpes, no one would answer it, first of all. Right? But 80% of us in here have herpes. It's just the stat. Right? If you've ever had a cold sore, you have a latent herpes infection. Does that mean that, you got the herp and you're bad? No. And there's actually a great, if you guys are ever interested in that, there's a great, you guys ever seen the show Adam Ruins Everything? I think it's True TV. If you get a chance, there's actually a great Adam Ruins Everything that covers herpes. And it talks about why we have a negative connotation for herpes nowadays. Why do you think we started getting a negative connotation for herpes? What do you think the goal was? Why would the pharmaceutical industry want us to have a negative connotation for a virus? Yeah, to buy drugs for it. Yeah. So, I mean, there are medications, acyclovir, that helps treat herpes infections, right? What's the one? Abreva, right? Abreva to help with cold sores in the first couple of days, right? So yeah, let's see where we're at here. Let's take a break here. So we're about an hour into it. Let me pause the recording. All right, so we're back from recording, or yeah, back for recording. We're back recording from break. That works. So the last thing we had kind of talked about was the adverse reaction side effects, right? Then we need to talk about dependence and addiction, because this is an important thing when we talk about pharmacology that we have to understand. Tolerance, dependent, and addiction are not all the same thing. So tolerance is usually one of the first steps in either dependence or addiction. When you're starting to become tolerant to the drug, your body slows in response to the drug, meaning you need greater and greater amounts to achieve the same effect. This is really common for your illicit drugs like heroin and your opiates and stuff like that, where maybe initially you took one oxycodone and you got the happy feeling that you got. Well, over time, melatonin, yep, exactly. Melatonin does the same thing. You're exactly right. You take 10 milligrams of melatonin the first time and out, you're gone. And then if you take it for a while, you're like, oh my God, it's not doing anything. So now I got to take 20 milligrams, right? You build up a tolerance to it. And you're going to need more and more to get the same results, right? This is why a lot of patients turn to things like heroin. Because, whether, I don't know if you guys know this, but I'm assuming you do. trying to get oxycodone and hydrocodone and stuff like that from docs is actually not as easy as it used to be. And then buying them out on the street is really hard. It's really expensive, right? Now, some people still do it, but heroin is cheaper in the long run based upon usage and stuff like that. So tolerance is the ability to build up kind of a dependence on the drug, right? Or build up that response. Tachyphylaxis is a unique form of tolerance. It's a rapid developed tolerance, sometimes in its first dose. I've actually seen patients get this with pain meds. They get their first dose of pain meds and instantly build up a resistance or a tolerance to it. And so they come back with the same level of pain meds 4 hours later, and it does nothing to them. It doesn't even take the edge off the pain. It's just a weird way that the body reacts to the drug. They get a tachyphylactic relationship, a rapid adjustment or tolerance, right? Tachy meaning rapid, phylaxis meaning tolerance. Then we'll get onto the topic of dependence and addiction. Dependence is when you need the drug to physically or mentally function. Caffeine, for me, I am dependent on caffeine. I will openly admit that. Caffeine helps me function better, right? So I kind of need every morning, right? If you ever saw Mr. McKeever wake up in the morning, coffee to get me going in the morning, right? For some of you, it may be like 5-hour energy. For some of you, it might be one of those bang energy drinks. Oh, God. I'm surprised I haven't been sponsored by Bang yet on our videos here. Maybe I should write them. Maybe they'll sponsor me. Say every time that I do a video for a school, I just throw a Bang. Yeah, okay, I'll do G Fuel. I don't think I'd do Bang. Sponsored by G Fuel. Use code Mr. McKeever for 20% off. So a dependence is where you need it to function. That is not necessarily meaning you're addicted to the drug. Addicted is where you mentally or physically crave the drug, right? Not all dependents are addicts, but all addicts are dependent. Does that make sense, that phrase? So not all dependents are addicts, but all addicts are dependent, right? So just because you're dependent on, just because I'm dependent on caffeine, I don't like, if I'm sitting at home and I don't have any coffee, I don't sit here going, I'm not gonna function, I need my caffeine. I don't try to run to the store really quick so I can get coffee because I need my caffeine fix, right? But all addicts that require the drug need that drug to function. Functional alcoholics are an interesting case of that, right? People that can literally drink levels that would knock us all under the table and drink it and function normally. Most drugs have a dependent factor, meaning you can become dependent for use, but not all of them have an addictive factor. And that was the big argument with Purdue Pharmaceuticals back in the day. Is Purdue said that OxyContin wasn't addictive. You could become dependent, and that was one of the things. They're like, you can become dependent on it, absolutely, but it's not addictive. And, for those of you that don't know the study, so they did a study, and I think it was the New England Journal of Medicine. It wasn't a study, it was a letter to the editor, first of all, where they listed this doctor that followed 10 cancer patients. And out of those 10 cancer patients, only one of them became addicted to the drug. So 10% addiction rate in medication is actually pretty good. But why do you think only one person became addicted to the drug? Gotcha, Renee. Why do you think only one of the 10 cancer patients became addicted? What do you think happened to the other 9? They died. But they touted this. Look at this great study. Only one got addicted. That's manipulation of statistics, right? Yeah, only one lived to tell the tale and he was addicted. So it's just one of those, that things can happen like that. Could you become addicted to like those Bang energy drinks? There are addictive personalities. I'm going to talk about that actually. Could you become addicted to the Bang energy drinks and your energy drinks? Do any of you know a friend that is? I actually know a couple people like that, Javen. I actually know a couple people like that for whatever reason, caffeine develops a very addictive personality to them. That they get the shakes and everything from not taking it and stuff. Like, it's kind of wild. I don't know. But yes, we do have addictive personalities, or more the fact that there's a psychology of addiction, right? There are a lot of studies that show if you have an addict in your family, you are likely to have addictive tendencies, right? I worry about that because, my family obviously is not the most highbrow family in the whole wide world, I guess we'll call it. And I have family members that are addicted to both alcohol and opiates, right? I don't know if I told you guys this, but my graduating class was a little under 100 students. There are only 37 of us left out of my 100 students that graduated my high school class. Most of the people that died out of that 100 passed away from opiate addiction. I think it was something like 90% of them have. And we actually just had another one pass away 2 weeks ago from opiate addiction. So there's definitely a psychology of addiction, right? And there's all kinds of things that you can tie into that. But the other thing is your brain sometimes is wired for you to become addicted to drugs, right? Those mu opioid receptors, especially when you're talking about opiates and stuff like that, they just really absorb that and like that drug, and you become addicted to it. Yeah, it's kind of terrifying. So placebo versus nocebo effect. I'm sure we've all talked about the placebo effect, but it can affect other things, not only drugs, right? So what is the placebo effect? What does that mean? What does placebo mean? Yeah. So sugar is typically thinking research, right? The sugar pills. So a placebo effect is where you get a positive effect from something, even though you don't necessarily get it, right? So when we're talking about research, if we do a double-blind study, 50% of the population will get the drug, 50% will get a sugar pill, right? Of those people that get the sugar pill, there's a certain percentage of them that will suffer the placebo effect. That means they'll show the same results as the people that got the drug, even though they didn't get it. Isn't that wild? Because that literally means what caused the effect to happen. Yeah, the mind, right? The brain. Like, if we could figure out how to trigger that, we'd be set, wouldn't we? I mean, that's just kind of wild. So placebo effect is, for example, I remember this one time, I had a patient that was doing ultrasound on. And I was sitting there doing the ultrasound, and the patient was like, "Oh my God, this feels really good today. It's really helping my pain." And I'm sitting there for about 5 minutes, and I'm like, "Man, why hasn't the ultrasound machine gone off yet?" And I looked over, and guess what I forgot to do? Forgot to start it. So I was literally just sitting there moving the ultrasound head through the gel, and I never started the machine. But the patient, for some reason, got a positive result out of it. And it really didn't. That was a placebo effect, right? So if we have a placebo effect, we also have a nocebo effect, right? A nocebo effect is where the patient suffers a negative effect of a drug despite not getting the drug. Same idea. We got the drug people over here that got the drug. We got the sugar pill over here. Now, these sugar pill people hear that this drug may cause anaphylactic shock, and one of them suffers anaphylactic shock. That would be a nocebo effect. Even with that, with the people that are over here in the drug category, you still could theoretically trick yourself into the negative effect of that drug. You could have a nocebo effect, even though, and that's why it's really difficult with research, because was it a nocebo effect? We told them that they would get an anaphylactic shock and they got anaphylactic shock, or was it actual anaphylactic shock from the drug? Does that make sense? That's kind of a wild thing to think about, right? So this is why we talk about watching the terminology we use in physical therapy, right? If I keep saying, does this hurt? Does this make things worse? What does that set in the patient's mind? That physical therapy should what? Make their pain worse, should hurt. Yeah, right? So I'm setting them up for a nocebo effect. Could I set them up just the same for a placebo effect? Sure. Right? I've done it before where I'm like, oh yeah, I did this therapy with one of my other patients yesterday, and man, they got some really good results out of it. It felt really good. And, this is a new stretch I just learned. We're going to do this thing called blood flow restrictions. It's appropriate for everybody. But then you've got to ask, are they getting, because this is the question that, and we still psychologically are still trying to figure this out. How do they get a physiological response out of this? Because there's actually people, when they tested them after they've gotten the placebo shot, that their IgG still kicked up. So their brain literally not only triggered a mental effect of getting the vaccine, but it triggered a physical effect too. I don't know. That type of stuff is amazing to me. That's that psychopharmacology part. I can tell every one of you is really interested in that. So at the top of this, all these drugs here, I put SB 2019, page 246. Score Builder's book, which you're getting, 2019, page 246. I did this to help you. You're very welcome. This way, when you're getting ready to study for your boards, there are pages you can reference right out of the book for pharmacology. So we're going to talk about neuromuscular pharmacology first. So neuromuscular means that the drugs are going to affect the neurological system to trigger a muscular effect. So the first classification of drugs, and this is drug classes, are anti-epileptics. What would be the other term we would call these? Anti what? Epilepsy goes hand in hand with not strokes, the other S word, seizures. There we go. Right? So anti-epileptic drugs. So anti-epileptic drugs, we have Dilantin and Tegretol are two of your main ones that we give them. Who is going to be on an epileptic drug? A patient who suffers seizures. The interesting thing is all of these medications, all these neurological medications pretty much have the same side effects. Lethargy, sleepiness, reduced function, right? So that means if you have a patient on any of these drugs, what's one of the most important things you should put on them? Gait belt. Yep. So we have the anti-epileptics. Now we have the antispastic drugs. So these drugs promote relaxation at the muscle fiber level, right? So what type of patient might have spasticity? KRLS, right? What about somebody that's got Parkinson's? Do they get spasticity? Yeah, right. For me, I usually think of my patients that have cerebral palsy. right? Especially spastic cerebral palsy or spinal cord injuries or strokes, right? So the antispastic medications, just so that I'm trying to make this as like bare bones simple as possible to understand the drugs. They promote relaxation at the muscle fiber level. Baclofen and dantrium are two of the most common ones. Baclofen is probably the one you hear about most. So we have antispastics and muscle relaxers are close to it. We'll talk about that at the bottom. But remember that antispastics kind of at the muscle level. And then we have dopamine or acetylcholine replacement agents. What are we replacing with those? Other than dopamine and acetylcholine, what are those called? What's the technical term for dopamine and acetylcholine? They are, it starts with an N. Neurotransmitters, yeah, right? So when you're on a dopamine or an acetylcholine replacement agent, you're trying to improve the amounts of those in the system. L-Dopa and Cinemet are common ones for Parkinson's, right? Then you have anti-ACH and Metopar for acetylcholine. So just to remember for this one, is dopamine excitatory or inhibitory? You remember that? You have 50-50 shot here. Okay, so I've got excitatory, I've got inhibitory. We have 50-50 showing here. Because remember, dopamine and acetylcholine are kind of two sides of the same coin, right? One of them is excitatory, one of those inhibitory. So dopamine is the inhibitory one. Acetylcholine is the, and this is the way I remember it, is this helps me remember it. With Parkinson's, dopamine levels are low, so then they get the tremor, right? So they're excited. Does that make sense? Because the acetylcholine levels are higher. So that's the way I kind of help remember that when I was going through school. So if I take dopamine, I'll slowly slow down my tremors because I'm starting to inhibit that bad chemical signal. Does that make sense? So dopamine is typically inhibitory. Acetylcholine is typically excitatory. There are other effects they have, but just when we're talking about Parkinson's versus something like myasthenia gravis. So then we get muscle relaxation agents. These promote relaxation of the muscles at the CNS level. So where is that promoting this relaxation at? What two components of this body? Which two parts of this? What are the parts of the CNS? Brain and the spine, right? So versus antispastic meds, which promote at the muscle level, the muscle relaxing agents work at the CNS level. So Valium, Flexeril, Scalaxin, Soma. Soma is the big one. Don't you ever get in the way of an older patient and their Soma, right? Soma causes that muscle relaxation effect. It's really, but all these kind of cause sleepiness, right? And you may have even heard of Valium being used for other effects, but it is primarily a muscle relaxer. It can be used for other things. So then we've got musculoskeletal. So these are drugs that kind of help at the musculoskeletal level, maybe not necessarily at the neurological level. So disease-modifying anti-rheumatic agents. That's a lot. So DMARs. These are drugs that are going to help with inflammation caused by the immune system being out of whack, right? Rheumatrix, Areva, there's a couple of them out there. It just went away. I'll think of it in a second here. But they're the drugs that we see, you know, when you see them talking about for treatment of rheumatoid arthritis or treatment of, what's the plaque forming one? Why am I drawing a blank on it right now? Not sarcoidosis. Anyway, it's my brain's drawing a blank right now. But yes, yeah, so these drugs modify the immune system. If it's going to modify the immune system, what is that? What do you think one of the side effects of the drug is going to be? If it's reducing the effectiveness of the immune system, side effect is, yeah, it's going to weaken it, and they're therefore more likely to get an infection. Good. Glucocorticoid agents. Glucocorticoid agents are used to modify the cortisol levels in the body, right, to tamp down maybe inflammation. Can also be used for a couple other reasons as well, for weight gain and stuff like that if need be. Dermacortisol are kind of the common ones there. Non-opioid analgesics, pain relievers, right, that are not opioid related and they are not anti-inflammatory. Tylenol is kind of your main one here. Then we have NSAIDs, non-steroidal anti-inflammatory drugs, right? These are non-glucocorticoid, meaning they don't kick up stuff inside the body for inflammation. They treat it with its own. The most common are Advil and Aleve, ibuprofen and naproxen. And then we get down to the fun ones that everyone always wants, the opioid analgesics, right? Which are processed at the mu opioid receptors in the brain. Demerol, OxyContin, fentanyl, hydrocodone, oxycodone, even tramadol, which is a low-level one. All of those are considered opioid analgesics because they bond with the mu opioid receptors of the body. The important thing to know here, whether we're dealing with glucocorticoids, non-opioids, NSAIDs, or opioids, are any of those actually relieving the pain? No. What are they doing? They're Jim Carreying it. They're masking it. Yeah. They're just blocking the body's ability to feel it, right? And some of them pretty severely. Fentanyl, whew, that can seriously kind of mess you up. There's a whole thing right now. I don't know if I've ever mentioned this before, but there are people that in nursing homes will steal fentanyl patches from patients and then take them and chew them. Now think about that. Where has that fentanyl? Yeah, Achilles like, ew. Right? That fentanyl patch was on that old person, and now they're chewing it. Can also heat it up and smoke it as well, but that's what I get for watching all the Law and Orders. So cardiovascular pharmacology, out of all of these drugs, these are the ones that people freak out about the most. How many of you would say that cardiovascular pharmacology kind of scares you? All the drugs that affect the heart. Okay. Yeah, it does scare you just because there's so much. The main thing to understand with cardiovascular pharmacology is you need to understand the side effects of it. And when you're taking a drug that affects the cardiovascular system or even the cardiopulmonary system, you need to know it's going to affect my what? My vitals. That means what's going to be important for you to be taking constantly through the treatment. Vitals, right? Pre-vital, mid-vital, post-vital. As long as you're monitoring their vitals, you should be good. Which vital is probably going to be the most important to monitor to make sure they don't fall? Blood pressure. Yeah, right? If you're monitoring that, you should be good with most of these. So a lot of these questions, when they ask you something about a cardiovascular drug, what they're looking for is not, do you understand the difference between an AA or AAA and an ACE? They're looking at, do you know what vitals you should be measuring? And do you know how to be safe with the patient? So that would be putting a gait belt on them, maybe working them at a standard walker or walking them inside the parallel bars, right? So the AAAs, the alpha antagonistic agents, right? These typically Cardura and Minipress are your most common ones here. They are going to work at the heart level to reduce your overall workload of the heart so the heart can function a little better, pumps a little bit better, right? The one we hear a lot are the ACEs and the betas, right? Angiotensin converting enzyme inhibitor agents, or ASIs. This is your capoten, vasotec. And again, I look at these and go, most of them kind of tell me, when I see Cardura, I know it's a heart medication. When I see mini press, what should you think? Pressure, right? Capoten and vasotec, not as easy, but vaso, vessels, right? Heart med. They're gonna inhibit that ACE from pushing a hard charge on the heart and can help your heart pump a little bit better. Anticoags. Remember, anticoags are not blood thinners. Blood thinner is water. Your major anticoags are heparin and coumadin, right? Which are variants of rat poison. So heparin and coumadin are your anticoags. So both your anticoags and your antithrombotic, what do you think your side? Yeah, it is rat poison. Your antithrombotics and your anticoagulants, the major side effect is going to be the patient bleeds and they bruise easy. So it's just important to kind of know that. Anti-hyperlipidemic drugs. Can you break that one down and tell me what that's for? Anti-hyperlipidemic. Yeah, right? It's high cholesterol drugs, right? Lipitor, Zocor. Those are your kind of common ones here. So those are the patients that are having high cholesterol. Yep, atorvastatin. Yep, the statins are common there. So with that, again, the patient probably has really, really high cholesterol, which means their blood vessels are kind of goopy, right? And so then we're going to be watching for things like strokes and pulmonary embolus and blood clots. Antithrombotics. So antithrombotic, when I see antithrombotic, it is a super duper anticoagulant. So the antithrombotics are literally going to go in and burst clots, right? Your TPA from the stroke lecture, if you remember correct, the tissue plasmagenic activator is like a major version of that. But these drugs are going to, rather than keep the blood from clotting, it's not only going to keep the blood from clotting, but it's also then going to break down clots. Carbodiol count is which one? Yeah, I'm sorry, Jared, I'm sorry. Which drug? The antithromb? Yeah, I think it is. I think. Let me get back to you. I just want to double check before I say yes for sure, but I think it is. I'm not familiar with that one, so I want to make sure before I say it is. And then you have your beta blockers, right? Your tenofovir and your low pressure is probably your most common. Yes, actually, low dose aspirin would be an antithrombotic. Yep. Think about it. What's one of the things they give to a patient that's had a heart attack in the past? Low dose aspirin. And they don't give that to them so that, they feel better. The idea is to keep blood clots from forming, because if your heart's not pumping well enough, blood is likely to clot, right? So low dose aspirin helps keep things from clotting. And it makes sense. If you ever see a patient that's on a low dose aspirin, they tend to bruise really easy. When I was on that back in like 3 years ago, when they put me on that, it sucked. Like I'd bump my ankle and I get a huge black and blue mark from just bumping it. It was really annoying. There are also calcium channel blockers. And I like the calcium channel blockers a lot because it's really easy to tell what they affect. Isn't it? Looking at the names, Procardia, Cardizine. They're going to affect the heart, right? Again, going to help the heart pump a little bit better. Diuretics. These are the ones that most patients hate because what do diuretics cause them to do? Not poop, the other, pee. Yeah, right? These are the patients that because they have congestive heart failure, they've got really bad localized swelling. And so now they take them to get the urine, to get that fluid out, but the side effect is they're going to pee a lot. Right? And so then they stop taking them and they start swelling again. This is a vicious cycle with them. Duril, LASIK is probably your most common one. Nitrite agents. Erica probably has seen a couple of these when she was working with the cardiac patients, right? The nitrite agents are for rapid drops in blood pressure, right? So nitrostat and glycerin tabs, the glycerin they give you under the tongue, the patches, right? Does anyone know what the major side effect of, oh, actually all of these, one of the major side effects for anything that affects the heart or the blood vessels are headaches. Why do you think you're going to get a headache? Well, if you've got a drug that opens the blood vessels up, right, like your nitrates, when they open up, you get fast blood flow, so your brain gets a rush of blood, right? The other side effect is if you have one that slows down your heart to keep the heart pumping a little bit better, it reduces the blood flow to your head. So you can kind of get a combo effect going there. The nitrates, like that was the worst headache I have ever had in my entire life is when they slapped that nitro patch on me. And I've had I suffer migraines every day. That headache, I would never want to live again. That was the worst headache I have ever had in my life, right? And if any of you take anti-migraine meds, one of the effects of the anti-migraine meds is to close off some of those vessels, vasocompress the vessels in order to reduce blood flow to the brain to stop kind of that overpumping action. Positive inotropic agents, Lamicin, I really wouldn't worry about that one. That one, it's in the book, but I can say I don't think I've ever actually seen that on a patient's chart. But again, it's a help the heart work better. And then here we have, so we have the antithrombotics and then we have the thrombolytics. So TPA technically, I guess, would be more of a thrombolytic. Thrombolytic, kinolytic, activase, TPA, all of that is going to absolutely destroy, it literally is going to shut down the body's ability to clot. So that's why we think about if a patient comes in with a stroke and we suspect that it's a blockage stroke, but it turns out it's hemorrhagic, and we give them the medications, we can cause them to die because their brain will just literally bleed into itself and they'll die from bleeding out in the brain. Endocrine pharmacology. So endocrine, if I'm looking at my pharmacology levels to study for the boards, neuro and muscular, cardiology, endocrine. Somewhere behind the chair. It's pretty rare that you're going to get a lot of questions on endocrine replacements. You may get something. That's okay, Tyler. Thank you. I'm here no matter what we're recording it. Don't you worry about it. Bone mineral replacing or regulating agents. What type of patient might be on these drugs? Older what? Yeah, older women. Good. Fosamax is probably one of the more common ones. Boniva's out there as well. The idea of these drugs is to allow the calcium, patients with osteoporosis, right? To allow the calcium to get absorbed a little better and try to prevent some of that osteoporotic effect, right? Hormone replacement agents. I love, this is my explanation for this. There are many out there. Their job is to replace, guess what? The hormone, right? So if you have a patient that is on estrogen, it is doing what? Replacing estrogen. If you have a patient that is on anabolic steroids, that would be a hormone replacing agent, right? So that would be replacing. Now you can be on anabolic steroids for positive reasons, and you can also be on them for less than positive reasons. Thyroxine. hormone from the thyroid gland. That would be on patients that have either hypo or hyperreactive thyroid, depending upon what they're using it for. And then we have hyperfunction agents. These are hormone replacement drugs that reduce the function of a hormone. So like an anti-calcitonin would be used to suppress calcitonin. An antithyroxine would be one to reduce thyroxine. They don't name these very fashionably for the endocrine because they're not as sexy as the other drugs. If you're getting a hormone replacement drug, most of the time, you're not one of those big ticket clients anyway. So they just kind of like, here's their hormones, take them. When else might we see somebody that's on hormone replacement drugs? Yes, gender reassignment, right? We have to be thinking about that, especially nowadays. It's not something that's hidden anymore, right? Back when I was coming through school, we didn't see these patients because a lot of them were scared to come into medical clinics because of the biases and stuff like that. But it's becoming a lot more common now for you to see people that are going through gender reassignment, right? If I'm male and I want to take on female characteristics, I have to take higher levels of female hormones, right? Otherwise, the testosterone will kind of always override it. If I'm female, I need to take testosterone agents in order to give me more of a male appearance. And I am not going to debate at all about gender reassignment or gender selection or anything like that. That is not something I will debate. Those people that are going through it, if that is what they want and that is what makes them happy, you should be happy for them. That's the extent of where I'll go with that, right? Everyone should do what they want to do and just ignore their biases. Be a little bit more open here, world. Just saying. But thinking about that, if we have a male who is taking female hormones, that's going to put them at risk for some of the female type diseases like osteoporosis. So they have to be aware of that. If you have a female who's taking male-based hormones, meaning testosterone, they could get the side effects of just like an anabolic steroid, where they're going to get, rage issues, back knee, all that kind of stuff. So we just have to kind of be aware of that. Gastrointestinal pharmacology. Again, another one. If endocrine's back here, gastrointestinal is about here. Antacids are kind of the most common one. I love when patients tell me they're on antacids. Yeah, I'm on Tums. 90% of the world's on Tums. Just saying. They pretty much are. Right? Milk of magnesia. Milk of mag is another common one. Antibiotics are technically considered GI drugs because they're processed in the gastrointestinal. So your tetracycline, your amoxicillins, your I'm drawing a blank on the other ones. Anyway, those. Intestinal anticholinergics are used to suppress acetylcholine at the gastric level. So the only one that's really there is gastrozepin, and they're going to have the same side effects of cholinergic, right? Antidiarrheal. The most common one is bismuth. What is the brand name for bismuth? Pepto-Bismol. Heartburn. Was it heartburn, whatever, diarrhea? Call Pepto-Bismol. Forget that one. Capectin's another one. Thank you. There it is. Gyra knows the jingle. So antidiarrheal agents, the goal is to stop them from having diarrhea. And then your antiemetics. These are drugs that make you not Vomit. Yes, it is. Absolutely. Yep. It's a powdery stone. Well, think about it though. Let's think about this for just a quick second. It's like a chalk. Oh, yeah. Now it makes sense, doesn't it? Balances pH levels. Yep. There you go. Wouldn't ever see learn something in my class. Amazing. So scopolamine, meclizine are all considered antiemetics. And if you remember correctly, Mr. McKeever has already talked about meclizine as being a anti-dizziness drug. But meclizine in and of itself is used for stopping you from vomiting. The interesting thing was meclizine was generic and it was used for anti-vomiting. And then someone realized that we could also use it for inner ear infection or inner ear problems, not infections, but problems with the vestibular system. And so they rebranded it Antivert so they could get more money from it. Just saying, I wish I was like a pharmaceutical person that made a lot of money. More anti-emetic. So emetic agents are different than anti-emetic agents. Anti-emetics stop you from vomiting. What do you think emetics will do? Yeah, induce it. Apomorphine, but the more common one is Ipecac. And I guarantee, has anyone ever seen anyone get Ipecac before? Yeah, I guarantee if you ever see someone getting Ipecac, you will never eat waffles and pancakes the same. Because Ipecac smells like really, really strong maple syrup. And it has the consistency of really, really thick maple syrup. And like to this day, I have a visceral reaction to Ipecac because I had a friend that actually overdosed and they gave him Ipecac. And that smell has forever lingered in my brain that now, like if I go to get pancakes or something like that and I put syrup on my pancakes, or the other one is maple donuts. Anytime I smell a maple donut, I just get that, just this visceral reaction. I'm like, okay. Yeah. Well, oh, I can't walk into a Waffle House to begin with. But so Ipecac causes it. H2 receptor blockers. You may have seen these before, Tagamet and Pepsid. They usually go hand in hand with proton pump inhibitors. What kind of condition are both those going to be used for? So your proton pump inhibitors and H2 receptor blockers. GERD, right? Gastrointestinal reflux disease, or high stomach acid content, right? And if you see H2, what do you think it's blocking? Hydrogen. Yeah, right. What is primarily the acid in the stomach? Hydrochloric acid. So it helps keep that from getting too bad. Laxative agents. Laxative agents. Now, Jaira, what do laxative agents cause you to do? Those are the poopy ones. Yes. Citracel and cholates. Citracel is magnesium citrate. I forget what cholase is. And they may be magnesium citrate either. The only thing I'll say is if you take those, better be by a bathroom. Those are something you don't want to take on a road trip. That would be a crappy situation. Good. I made somebody laugh. And again, proton pump inhibitor, I told you, I kind of work with the GERD patients. Now my fun ones, psychological pharmacology. These are the drugs that people oftentimes actually want because some of them have some really good side effects. Anti-anxiety agents, Xanax. Some of you guys might need this before your exam. Right? Some of you may be needing that before you go out in clinicals. It'll be Xanax o'clock, right? Xanax and wine do not go well together. Just warning you. Not that I know from experience, but Xanax and wine don't go well together. So again, one of the main things for all of these, because we're going to go down through them all, one of the main things for all of these, the side effects, lethargy is the major side effect, and get loopy. Yeah, right. Most of them also have a frontal lobe inhibition. So they inhibit your frontal lobe slightly. So what could that cause you to do? Not think clearly, make bad choices. Yeah, right. Take Xanax and go out to the bar once. You might not be happy with the outcomes. I'm not saying to do that. Please don't do that. But you can make really bad choices on some of these drugs. So we have our anti-anxieties. We have our antidepressants. Antidepressants are named after what they treat. So you can have tricyclics, which work on a lot of the 3 cycles of your mood. You can have SSRIs, selective serotonin reuptake inhibitors. You have MAOIs, monoamine oxidase inhibitors. Norepinephrine reuptake inhibitors. You can have mixed versions of antidepressants. The main idea for antidepressants is to level your mood. And I'm going to say this again, if any of you ever get on antidepressants, you will be the last one to know they are working. Because you don't know they're working. Who knows they're working? Yeah, people around you, right? I openly admit this. Back, I was going through my divorce, and I had a lot of I was having a lot of stress. They put me on Wellbutrin, and I didn't notice it. Okay, Alexa. I didn't notice it. I didn't really notice how it was affecting my mood, but everyone around me was like, man, you're not as grumpy of a bear as you normally are. So I should have took that as a compliment, I guess. Maybe I need to start taking it again. It'll help my mood. I could definitely need it with today's political climate. But all of those are going to affect and level out your mood. So if you look at the antidepressants, you don't have to specifically know which one's an SSRI, which one's an MAOI. You just have to know they're there to level off the mood of the patient. And again, with antidepressants, it can be 6 to 8 weeks until they start kicking in, which is why it can be really strugglesome for, and I don't know if any of you are on antidepressants. I don't want to know the answer to that. I'm not asking you. But it can be really a struggle when you're working with your doctor to find the antidepressant that works for you. Because we may be thinking it's an MAOI-based depression. So we get you on MAOIs, we have you on it for 8 weeks, it doesn't do anything, right? Then we may have to change you to an SSRI, or we may have to change you to an NERI. We may have to combine to a mixed one. So all of that kind of comes into play when you're taking these antidepressants. It can be really rough for not only you, but the doc as well, to try to figure out what works best. Antipsychotics. If you hear the nurse calling for Haldol, it might be time to run. Hopefully they're not calling it for you. But if they're calling for a Haldol dose, it means that you've got a patient that's having typically a psychotic break. And just remember, with any of these drugs, we cannot just give a patient Haldol. We have to have a what? Yeah, doctor's order. So this can be really frustrating for families if they have a family member that's going through a psychotic break in the hospital, because the nurse has to call and get a doctor's order before she can prescribe Haldol. So it can take time to call the doc, get the order called in, get the order put in the system, get the Haldol up from the pharmacy and administer it. Nurse would just say, I started him on Haldol, and I say, okay, I kind of know what it is. Yeah, Haldol's major side effect is it just knocks you the crap out. I almost said something bad. Knocks you out, right? Thorazine's another one that's a little bit older of one, but it's just, again, Thorazine's one that if somebody's psychotic, that's one of the ones you're typically on a regular dosage. Bipolar medications. I have a funny story about these here real quick then. Bipolar medications are made to keep you from doing one of these, right? Patients that are bipolar go manic, then go depressive, and they go manic, and then go depressive, right? The bipolar medications are supposed to level you off. Lithium and Tegradol are pretty much the two common ones. Bipolar medications, the major side effect for them is weight gain. A lot of weight gain. Like they're on lithium, it can be 40 to 50 pounds of weight gain. So that can be a reason why people that are having bipolar don't want to take it. There's that new drug that promises no weight gain. I forget what they just advertised on TV. I can't think of what it's called. But funny story about this, just so that you guys I can give you a little bit of Mr. McKeever humor here. My ex-wife had a friend who was antipsychotic and bipolar. Yeah, it slows down it drastically slows down the metabolism and speeds up the appetite. Yep. But anyway, she was bipolar and antipsychotic. And she lived up in the middle of nowhere in Pennsylvania with her husband. And remember, we were walking out in the field and she was talking to me because she talked to me a lot. And she's like, you know, sometimes I hear voices in that creek over there. And so Mr. McKeever, being Mr. McKeever, decides to crack a joke at it and goes, oh, so it's a babbling brook. And she like turns to me and deadpans, sometimes the voices tell me to dismember you. And just turned and kept walking away. I was like, going home now, going home now. That was probably on hindsight, probably wasn't a good idea to joke like that, but it was still one of those. I'm like, that's one of the ones I'll never forget. And I just know I don't joke with bipolars or antipsychotics anymore. Sedatives. These are the ones a lot of people want. But sedatives, if you look, Haldol kind of crosses over antipsychotics and sedatives because they both do the same thing. They are also hypnotic agents, meaning they will cause you to do what? They'll cause you to trip. Not trip as in, oh, fall. Trip as in, whoa, dude. Halcyon, luminol, Haldol again. Mind focusing agents. This is one that is an abuse. Very, very heavily abused medication for ADD and ADHD. Adderall, Ritalin, Concentra. Why are these abused drugs? Because, man, they give you energy and they really help you focus. Like, I can't tell you how much these drugs will get you. Just literally, blinders are on. You'll sit down and, especially during periods, you see this a lot at colleges, these drugs will get sold around finals time, the end of the semester, because you can super get hyper focused. The downside to these drugs, all of these mind focusing drugs, is they are stimulants. Think about that for a second. That doesn't sound logical. Wait, if I'm having hyperactivity disorder and I give a stimulant, well, that's just the way the body works. Right? We give it to them and they actually get more focused and less kind of scatterbrained. Yeah, you can't sleep and you don't eat, right? They are also misused for weight loss, because you can lose rapid amounts of weight if you're on Adderall or Ritalin. But that's because you don't eat, right? If you look at it, if you actually look at the chemical makeup of Adderall versus methamphetamine that people make on the street, guess what? They're not that far off. Yeah. I mean, they're classified as amphetamine drugs, right? And it used to be that you could get these pretty easy. You used to be able to just literally go to the doc and say, I'm having trouble concentrating. And they'd be like, here's some Adderall. But now they've gotten a little bit more regulated on it. And so now, you have to have a diagnosis of ADHD. And I really honestly believe that in the children's world, there are way overdose or over diagnoses of ADHD. And this is just completely observational. I don't have a ton of facts to back this up, but I see a lot of kids that get put on ADHD meds that I think, well, they're just a kid, right? Especially boys. I don't know why it's particularly heavy in boys, but like, yeah, Kelly's like, I agree, right? Yeah, I'm not saying, this is not the boys will be boys argument for other things, but boys typically are giant balls of energy, right? Not that girls aren't as well. Girls can be too, but it just seems like for whatever reason, you know, parents think that because little Johnny is running around the backyard like a banshee, that he's ADHD. Well, maybe don't give him so many ho-hos and he won't be as ADHD, right? There's just some of that, but I think the reverse is also true in adults. I think there are too little adults that are diagnosed ADHD that could probably be diagnosed as ADHD. Just because, you know, my generation specifically, it was something that we really didn't talk about. A nutrient supplement, pharmacology. So this is stuff that provides us with nutrients and stuff like that. This also includes a lot of your herbal supplements. Your vitamins are the big one, right? And you have to understand which vitamins are fat soluble and which are water soluble, because you can actually poison yourself. If a vitamin is water soluble, can you really poison yourself? No, because what are you going to do? Pee it out. Yeah, right? Vitamin B is an excellent example of it. Does anyone here take a vitamin B regularly? I take a large macro dose of vitamin B because it helps with migraines, right? That, yeah, 3 hours later when you're taking a pee, yeah, you're glowing yellow. You have nuclear yellow pee. It was funny. I forget what I was going for a job once, and they had me do a drug test, and I took it. And the lady took my sample, and she's like, "Huh, you must take a lot of vitamin B." She's like, "Around here we call it vitamin P." I was like, that was funny. So fat soluble drugs are going to get absorbed into the fat and stay there. Vitamin A's, vitamin D's, vitamin K's, vitamin whatever, those 4 letters that I don't remember which one I left. When you look at a lot of those drugs, what do a lot of those drugs affect? Or not drugs, but the vitamins. Like vitamin D, vitamin E, and vitamin K are all good for your what? Does anyone know? Your skin. Yeah, skin and bones, right? And vitamin A, even vitamin A is good. Typically, you hear it for your eyes, right? That's why you're supposed to eat a carrot a day. And then your water solubles are the one you're going to pee out. So that means if you're going to take macro doses of vitamins, just be careful on taking macro doses of the A's, D's, E's, and K's, because they will get absorbed into your fat. Versus the water solubles, you pretty much pee out. Vitamin B, vitamin B3. Now, that doesn't mean you can't make yourself sick. Like when I take my vitamin B supplement, I have to make sure I have food in my stomach, because for whatever reason I take it, it kind of makes me nauseated if I don't have food in my stomach, right? And I haven't found a vitamin B that doesn't do that yet. Vitamin C, biotin, choline, pantothenic acid, folic acid. Yep. For folic acid, when do you hear that one commonly? What type of people should have high doses of folic acid? Yeah, mommies. Good. And then our mineral substances or organic substances used to replace minerals gained by consuming food. So your macronutrients, calcium chloride, magnesium, phosphorus, potassium, sodium, and sulfur. I don't know who takes sulfur on a regular basis. I would be worried that they're a demon from watching Supernatural. Chromium, cobalt, copper, fluorine, iodine, all those. The macro minerals we need in fairly heavy doses during the day. The micro minerals we don't need large doses. So there's really no need to dose extra heavy on fluorine, right? And in the area that I'm from in Pennsylvania, we had actually a big problem with this because of PFOA with Dow Chemicals and DuPont dumping PFOA into the water. And the fluorine that they were putting into the water sources turned people's teeth black. So fluorine at a certain level protects your teeth. At high levels, turns your teeth black. There's a great movie about that if you ever are interested in it. It has the Incredible Hulk in it, Mark Ruffalo. It's called Black Water. And I think if you ever watch that, you'll be worried about your cooking pans for the rest of your life. But yeah, so we need those macros and those micro minerals as well. But here's the deal with all of these vitamins and these mineral supplements. How can you make sure that you're actually getting these without having to take anything? Yeah, eat healthy food, right? Eat your green leafies, eat your roots, get your protein from your whatever you take for protein. I was going to say meats, but I don't want to offend anyone that's a vegan in here. Just eating healthy can take care of most of this. It doesn't mean that you may not want to take a multivitamin. If it makes you feel better, take it. The placebo effect, right? I'm pretty confident I take my vitamin B and it's just a placebo effect. I don't actually think it really probably helps with my migraines anymore, but it's now been taken for so long. I just think it just works. So one last thing here with the mineral supplements in that, those herbal supplements. So echinacea, St. John's wort. Trying to think of some of the other ones that are out there. Whatever. All of those different mineral or those different herbal supplements. I'm not going to tell you they are bad. I'm not going to tell you they're good because really we don't have a ton of research on them. I know supplements like glucosamine chondroitin. Has any of you heard of that? They usually recommend that for what? Joint pain, right? And UNLV did a study on it. Guess what they found about glucosamine chondroitin? Long term, it does nothing, right? I mean, I have the study somewhere on it, but they found really long-term glucosamine chondroitin really doesn't do anything. But again, this is not going to be one, if Jervin comes to me and says, well, Mr. McKeever, I've been taking glucosamine chondroitin and my joints don't hurt. So I'm not to be one to tell him, well, I read a research study that shows that glucosamine chondroitin doesn't work. If it works for him, it works for him. There's probably a placebo effect going on. Maybe it does with his specific biology, right? So don't be those Debbie Downers that are going to tell these people, well, right? Unless they're getting ripped off, because there are some really shady supplement companies out there, right? Especially on like actually, yeah. I know Kelly is involved in some of the extreme sports stuff and that stuff like that. There's a lot of people in those industries that push supplements that, may not always be the best for people. And even some celebrities do that, well, because they get paid, right? One of the big ones I just saw when I was on break, I had my TV on, and they had Frank Thomas and Doug Flutie on for, I think it's Testro X or Testafin or something like that. And if you read at the bottom, yeah, Flutie Flix. If you read at the bottom of the thing, it says, has been shown to not, in a clinical study has not shown to increase testosterone, free floating testosterone, but they're advertising it does, right? Understand with supplements, why can people make claims about supplements like that? They aren't what? Yeah, they're not regulated. Exactly. Now, they did crack down during the COVID period on some of that. Alex Jones comes to mind for this. And for those of you that don't know who Alex Jones is, please, you live a happier life. But at one point he was selling powdered deer antler and then the special fluoride, special non-fluoride, non-blah blah toothpaste that kills COVID. That's called profiteering, right? That's called profiteering. The government will come after you for that, especially during a pandemic. But for the most part, if it's not regulated by the FDA, they can say whatever they want. Theoretically, that was big, yeah, right? That was the mineral oils, the mineral springs people, and all that fun stuff. Absolutely, right? That's where we get the term what? There's a term for people that sell that. Snake oil salesman. Did you ever hear that term? Right? Hippies, true. Okay, well, maybe you're right. Snake oil salesmen were big in the 1800s going around America. And the reason they called them snake oil salesmen is guess what they were selling? Basically Proven. And it was to cure this and it was to cure that, and it killed a lot of people. I will classify along with these, the people that use, what are those things called? The oils, essential oils. Yeah. Now, if you use lavender because it has a calming effect on you, fantastic. Right? I'm okay with that. I use a lot of eucalyptus and spearmint because it keeps Mr. McKeever from having an aneurysm, because it does have a calming effect on my mind. I don't think it's going to cure disease. Right? And that can be really dangerous. There's just the whole topic of that where a mother did that with a kid who had really, really bad case of COVID. And she went on to her Facebook group for essential oils and asked them what essential oils she should use to cure the kid from COVID, and the kid died. Can be. Yeah, absolutely. Right? I don't think that spearmint in itself causes me to be calm. It's just a scent that I associate. Yeah, it's a scent I associate with being calm. Right? And if I can associate that, that puts me in a little bit better mindset. Same thing, I find that if I'm like chewing spearmint gum, I'm a little bit more relaxed. It's just a mind over matter thing. If you don't mind, it won't matter. Get it? Let's finish this real quick and then we'll take a break. So, oh my God, what the heck? So much stuff. First, take your anti-anxiety meds or antipsychotic if you need it. Okay? You need to know the safety of medications and how medications at peak efficacy may interact with each other, right? If you have two drugs that cause drowsiness, if you have a patient that's on opioids and muscle relaxers, what do you think the patient's going to be like when you go see them? They're going to be doppy, right? They're just going to be like, oh, that's too therapy. Yeah. They may be floppy and all over the place, right? It's important for you guys to kind of know what they're doing. What about if you don't know what a drug does that's on their chart? What could you do? Yeah, Google it, right? I have Pocket RX on my phone, I think is what it's called. Hold on, let me see what the name of the, it's under medical. Where's my medical folder? I don't know where my medical folder is. Let's see. What is the one I use? RX. Yeah, Pocket RX. You can use, there's Pill Finder that helps you understand. They'll actually, you can take a picture of a pill and it'll help you identify what pill it is. Right? Cops are using that a lot nowadays because they pull people over and they've got a baggie of pills in their pocket and they say, well, it's Tylenol. Snapshot. No, it's not. It's Adderall. Well, at least it got the all right, right? If you don't know it, look it up. And if all else fails, ask the nurse what it is. Hey, I see this patient's on this weird drug. What is this? I'm not familiar with it. And they may tell you, oh, that would be a bad nurse, right? But just take the time. Make sure you understand the patient's on. Now, most patients nowadays, you're going to say, what drugs are you on? And out they roll their scroll, of medications, right? Because we used to be a low kind of pharmaceutical use world, but now most patients, I think I saw the other day, it was like 3.4 medications per patient. And so if you guys are sitting in here and you think, well, I'm not on any medications, that's good. That means then there's somebody out there on 7, right? To balance it out. With the heart meds, almost all of them interact with the smooth cardiac muscle and reduce the overall workload of the heart. What's that going to do? What vital systems then? Or what do you need to monitor? Well, blood pressure and heart meds. Or not heart meds, blood pressure and heart rate. If I'm reducing the overall workload and the pumping of the heart, what's going to happen as I exercise them? Is their heart going to react normally? Is it going to automatically? Yeah, no, it's not. Right? So you have to be careful because you may not be able to put them on a 8 out of 10 RPE load, right? Rating of perceived exertion, because their heart may not be able to keep up with that. You may have to keep them at that kind of under 6 RPE. So it's just monitoring that. With the heart meds, what kind of symptoms would you be watching out for? What would you be watching for the patient to report to you? I feel what? Dizzy. Yeah. Dizzy is a sign that blood pressure may be off, right? What about if they say, I've got tightness in my chest? Problem? Yeah, right? At that point, the heart may not be able to communicate because of that medication they're on, so it's not beating right. Sometimes, and yeah, we didn't do too many of them here. The last class, cohort 8, got to see me when I was actually on my heart meds and got to take my blood pressure and my pulse while I was on it. And it had my heart rate and everything all over the place. Like I'd be, 60 beats per minute 1 second, 120 the next. So we've got to monitor that kind of stuff. What kind of stuff might we look for that they don't report, that we're watching them for? So we're looking at their body, looking at their face. Yes, sweat, good. Paleness, good. And cyanosis, right? Any bluing of the lips or bluing of the fingertips. We know that there's a problem with the pumping, right? And also just bruising. Like we start getting them out of bed and we notice they've got a big old black and blue mark on their hip. We might want to check to see what caused that, right? Because that could be an STDTI or suspected deep tissue injury. They were SDTI. With mental medication, almost every single one of them has a side effect of lethargy at peak and at trough effects, right? So at that time, the best time to see some of those patients is going to be maybe in the trough effects to make sure that they're not there. But if you have a patient that's psychotic, do you want to see them in their trough effect of their drugs? Probably not. Right? And for any that are interested in treating, patients that are on psych wards, it's a fantastic, I love it. They're my peeps. I love treating patients that have psychological conditions just because sometimes they're the most appreciative because no one comes and sees them. Jerry psych, yeah, right? So it depends. So it depends upon what drug they're on, Renee. If they're on maybe sedatives and stuff like that, definitely better to see them at the trough levels, right? Because that's when they're going to be most cognitively there. But if they're on or bipolar meds or antipsychotics, we want to see those people at the peak levels. Even though they're going to be less mentally there, they're less likely to throw a telephone at us. And I've had that. Actually, I remember the first time I worked on Jerry's psych, some little old lady threw a walker at me. And I asked her why, and she said, because you were there. Good enough answer for me. Right? So it just depends upon what kind of medications we're looking at. Same thing with like the antispastic. We may want to see them at the peak levels, but again, sometimes we may want to see them at the trough levels. Oh, that was a like fastball special. If you go back to Marvel and Wolverine, I came from nowhere. I didn't even see it. Just picked it up and flung it across the room. And it's amazing sometimes how strong psych patients can be. So the main thing I want you to get out of at least the basics of the pharmacology review is just make sure you understand what meds your patients are on. What if patient asks you, about their meds? Do you talk to them about their meds? Yeah, get the nurse. I mean, if they ask, hey, does opioids cause drowsiness? Yeah, you can answer that, right? Because we know that's a common fact. Stuff that are common facts, absolutely you can answer. But if they're like, do these drugs cause sexual side effects? I'm going to say I'm not a specialist in pharm, so I can get your nurse for you. I can refer it up to the doc. I don't know, right? What do you think? How many meds is too meds? Too many meds? Do we have a number? I don't know. What's funny is once we start getting past a certain number of medications, we start taking medications for the side effects for medications. And then we take another med for the side effect for that medication that stops the side effects from the other medications. Kind of gets scary. How do you deal with a polypharmac patient, meaning they're on a lot of drugs? Understand what they're on. Talk to them, right? How do you deal with a patient who does not report a specific medication at eval? So let's say they're talking to the PT, they get their eval done. You see them the next day, and the little lady's like, yeah, I took my Fosamax this morning. And you check the chart and there's no Fosamax on the outpatient chart. What should you do? Yeah, right. Subjective, good. Patient reports taking Fosamax today. And what else should you do? Tell the PT. Because the PT may have to come over and find out what level she's on a Fosamax and stuff like that to maybe adjust the therapy plan. Right? I had a patient once that was like, I was working with them and like, I think I'm going to go off my antipsychotic medications. And I'm looking at their chart. I'm like, they're not on antipsychotics. I'm like, let me go get the PT. Just going to be safe. What can you do to minimize your patients and your risk while working with patients on medications? Adhere to safety. Put a gate belt on them, right? With patients that have psychotic medication, stuff like that, maybe work on them in a private cohort room, right? Be aware of what's going on. Let patients know, or let your PT or PTAs or techs know if you're going into work with patients that might have certain problems. Maybe bring some help. If you got a patient that's on lethargy causing medications, it may be beneficial to bring some help for the few seconds and then say, okay, I don't need you. Always assume a patient is on some form of mind altering medication. This could be even alcohol. Always assume it. It's better to assume and be wrong than not to assume and that should have been right there on it, right? So just be careful with it. And also don't assume that pediatric patients aren't on medications. Kids nowadays are on more meds sometimes than adults. So don't just automatically assume with a kid, they're not on any meds. So we'll talk, this will be kind of the thinking process for after break. So let's pause here. All right, so we're gonna finish out talking about drugs here, and then we're gonna talk about the boards and stuff like that. So these are kind of some thoughts that you may ask yourself when you're working with patients. What kind of medications do you think a patient may be on that's over 65? Well, they're probably going to be on some heart meds, right? They may be on Lasix, could be on an antidepressant, right? Maybe some non-steroid anti-inflammatories. Now let's change that. What about a father or mother that's over 35? What kind of stuff might you expect them to be on? Any ideas? Maybe some antidepressants? Vitamins? child under 16, yeah, that's where we get weird. High blood pressure could be, absolutely, right? I guarantee if I have a kid, I'm probably going to be high blood pressure. Kids under 16, well, it depends upon the diagnosis. If they're cerebral palsy, they might be on baclofen. They may have muscle relaxants. They may be on ADHD meds. Recovering alcoholics. So when I say recovering, here's the deal. Do you ever fully recover from being an alcoholic? No, you are always an alcoholic, but you're recovering. Even to the day you'll die, you'll be a recovering alcoholic, right? So what kind of drugs might a patient be on that's a recovering alcoholic? Liver meds, good. Yep. There are even drugs that cause you to get sick if you drink alcohol. There are specific meds they can put you on that if you consume alcohol while you're on the meds, you actually get sick, which is ingenious. Sick as in vomit. Why would that be? Why would they give you those? Think about it. Are you less likely to drink if you know every time you take a drink, you're going to throw up? Yeah. Right. Especially patients that are those super chronic alcoholics that can't do anything. Right. Yeah, it's very similar to hypnotherapy, except as a drug. Recovering drug addicts. What's probably the one drug you're going to see a lot of patients that are recovering drug addicts that'll be on? Methadone. There you go. Right. And understand methadone is really nothing more than a restricted narcotic. Right. It has special coating on it, but it acts a lot like a narcotic in that it relieves the narcotic cravings. But again, just like that, just like a recovering alcoholic, you're always a recovering drug addict. You're never cured of being a drug addict. It can take one relapse and you're right back in it. Right. So this can be frustrating for families, especially if I don't know if any of you know any people that were recovering alcoholics or recovering drug addicts, because families just want the person better. Why can't you just stop using drugs? Why can't you just stop drinking? Well, it's not that easy. Right? It's just not that easy. Athletes. What kind of stuff might you think an athlete's on? Can an athlete be on pain meds? Yeah, especially if you're talking like professional football, basketball, soccer. Roids. Yeah. We got to watch out for those roid rages. Depending upon, again, with the world we're in now, it could be hormone replacement, right? So I don't know. You got to be paying, kind of think about it when you're working with the patient, what kind of meds they might be on. What should you as a PTA avoid? Talking about specific meds. This is the number one mistake I see new PTAs make. Patient comes in and they're talking about their symptoms, and PTA is like, oh, yeah, I had depression like that too. And then my doctor put me on this antidepressive med and I feel so much better now. Or maybe you should talk to your doctor about getting some pain meds. That's not for us to do. We listen to the patient, right? This can include recommending vitamins and supplements. And this goes double if you're a sales representative for things like Herbalife or any of those. If you are one of these individuals, you need to inform your employer. Your workplace is not somewhere to build your downline. And for those of you that ever encountered that, you understand what I mean by saying improving your downline. Right? You should not be selling your patients whatever you are on or whatever you're selling. Is that a conflict of interest? Yeah. Right? And the other thing is, what happens if whatever you sell them either doesn't work or makes them sick? They're coming back at you because you're a healthcare professional. Right? You told me that this would relieve all my pain. Right? So please I'm not saying that being a representative for any of these companies is bad. That is not what I'm saying. If you want to sell Herbalife, you want to sell, I forget what there's one that's like the shake one. I forget what those are called. There's a bunch of them out there. If you want to sell them, fantastic. Go for it. Make all the money in the world. Just remember your patients aren't your clients. And that can get you in some real hot water, especially at hospitals. I had a PT once that was big into Amway. And at the end of every single one of his PT evals, he gave an Amway speech to the patient, trying to sell them on Amway. And that's just not something you should do. Right? Code G Fuel, code Kami Keeper for G Fuel. No, just kidding. Don't be anti-medication either. Right? So yeah, I mean, I talk that patients can be on too much medications, but don't be anti-medication. Some patients need their meds. Some patients need them to function. Just because you don't like opiates doesn't mean you should judge somebody for being on them, right? What's that old story about glass houses, right? Don't throw stones if you live in a glass house. Same thing here, because maybe sometime down the line, you might need that med, right? I've seen a lot. I've seen actually PTs do that. PTs and PTAs do that a lot, where they're like, oh, I don't want any pain meds. And then they go for a knee replacement and they're on opiates. It hurts. Yeah, but you're preaching to the patient they didn't need it. Yeah, well, I'm different. I don't have a high pain tolerance, or I have a high pain tolerance. One of those two, right? Just the main thing here with medication, I know this is difficult, but try it. Be logical, right? Be logical about what you're talking to your patients about when it comes to medications. If you don't know, don't speak, right? I think Gwen Stefani told us that. So just think about that when you're working with them. I can't even get anyone to laugh anymore. Just pay attention to what you say and pay attention. It can be hard because we all have an inherent bias, right? I love pharmacology, so I want to talk about it when I'm with my patients, but I have to go, not my realm, stop. Now, let's say you're out with friends. You're not in a professional setting, and your friends are talking about, you know, are opioids bad or opioids good? Is it okay then to discuss it? Yeah, right? I always preface, and actually a couple of you asked me about certain things. And one of the things I always preface my statement with is, this is not my medical specialty, and this is my opinion, not medical fact. Yeah. And it may seem weird, and my friends stare at me when I say those things, because they're like, yeah, duh. Well, I'm just covering my butt in case one of you guys decides to sue me. Not that any of my, well, actually, probably some of my friends might. But yeah, casual conversation is not a recommendation, right? Be careful though, because everywhere around you, well, maybe not right now, but once we get back to normal, everywhere around you, a patient could be. Right? You got to be careful what you do. I just saw a PT the other day, saw a PT, I read an article about it, who, you know, it's not related to medications here, but the PT, I forget what it was, I think it was in Georgia or something like that. I forget where, or somewhere down south. The PT started an OnlyFans account. And if you don't know what that is, I'm not going to tell you. But some of the patients found it. Right? So this is one of those where even though you're not necessarily on the clock as a PTA, you kind of have to pay attention and think that you're on the clock most times. That's an uh-oh moment, exactly. Right? So just be thoughtful of that when you're working with patients and when you're talking to patients or when you're out in public. And here's the deal. To me, I don't care. She wants to have an OnlyFans account, more power to her. It's just that some employers could consider that a conflict of interest, right? But yeah, I mean, paying student loans is exactly right, Erica, right? So that's one thing. So if you're out with your friends and your friends are discussing maybe something like opioid addiction and stuff like that, just pay attention to who's around you. Pay attention if you're, vaccines, right? If you guys have strong opinions of vaccines, that's okay. I may make you angry, right? Because I talk about the medical efficacy of vaccine, but maybe you're just one of those people that doesn't believe in vaccines. I don't know why you would be, but maybe you are. Just be aware when you're talking about that type of stuff in public, because that can come back to you. Social media, right? Oh, I got glasses are crooked. Social media is another place that can get you in trouble. If you start posting stuff about medications or vaccines or stuff like that, just remember that if it's on the internet, it is what? It is forever. Yes. Right? So be aware of that. It is forever if it's on the internet. Right. So that pretty much covers up the dealing with the pharmacology. Like I said, once you get your book on that PowerPoint that I marked, I'm going to talk a little bit about this book right now, since you guys are getting it. So this is the PT exam book. This is the Score Builders Complete Study Guide. You'll notice, even though I don't have to take the test, I still have all kinds of tabs on my book. So one of the things you should do with your book is mark stuff that you think that is going to be important for you to study. What might be important for me to study, Mr. McKeever? Stuff that you're weak in. So when we get these books to you, let me find one of the chapters here, musculoskeletal. One of the first things I did when I got my Score Builders book is, I'll try to get this in focus. I don't know if it will. In each chapter, it's going to be reversed because we're in a camera. In each chapter, there is going to be this table of contents, okay? What I did with my table of contents when I got my book was I went through each chapter and I had a system. I don't care what your system is, come up with your system. Mine was stars. So if it had a 1 star, I felt good about it. If it had a 2 star, I wasn't as comfortable with it. If I had a 3 star, that was one area that I felt I was really weak in. So I would go down, like here I have musculoskeletal. So the first section is exercise physiology. I was like, oh, I'm kind of strong in that. I'm going to star that. And the next section, kinesiology. Oh, that includes gait, doesn't it? Star, star. And then muscle action and muscle testing. Oh, I'm good with those. Single stars. Oh, gait. Oh, crap. Not gait. Star, star, star. Right? Osteokinematics. Oh, that's that roll, spin, glide stuff. I better review that. Star, star. Now, don't be one that's just going down star, 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 star. If you did that, you're not going to have any benefit. Right? This is a good way to get you started. Right? It really helped me to kind of think through this, because that made me feel better when I went to like neuromuscular. I'm like, oh, Parkinson's. Yeah, I've got that. I'm okay. Right? But then I looked, I'm like, oh, myasthenia gravis. Oh, not so great. So once you kind of look through the table of contents, in each chapter of this book, you get to the back here. In each chapter, there's going to be gold, bronze, and silver sections. What do you think those represent? So there's going to be a gold, silver, bronze section at the end. Those are summaries. So they're ranked based upon what your test may ask you. So that means if I'm studying musculoskeletal, I should focus most of my stuff on the gold aspects of musculoskeletal, because those are going to be where most of my questions come from. And then if I'm comfortable and done with gold, then I move on to silver. And then bronze are the questions are going to be maybe one, maybe two questions on, you know, versus gold, which would be 30% of the questions or 40% of the questions. Scott does a really good job of dividing those up in here and helping you kind of focus on what to study. It gives you kind of that little bit of a mental straight line on where you're going. So I do the same thing. I'm going to go, so I did musculoskeletal, then I'm going to go to neuro. I'm going to look at my beginning chapter. I'm going to rank them again. I'm going to go to my gold, bronze, and silver, or gold, silver, bronze. At some point, I'm going to get that right. This is why I was not in the Olympics. And I'm going to kind of just breeze through them. Feel free to read the whole book if you want. Go for it. But that's not going to help you study. You have to have an attack plan. So how do we develop your attack plan? Because like, I think, I forget who it was, when do I study? Yes. What we are going to do and what I'm going to do is we're actually going to take some practice tests out of these books. I'm going to take those practice tests and put them into a database I have. That database is going to help me then design a study plan for you. So it'll break up your studying. So it might say musculoskeletal for a week, neuromuscular for a week, pathology for a week, modalities for 3 days, back to musculoskeletal for a week. It helps guide you on what you need to study based upon what your weak areas are. It'll also kind of focus you a little bit so that if you're like, oh, well, you know, I don't know what to do right now, you can pull out a study calendar and go, okay, yeah, that it helps a lot. And here's the deal. I'm going to be 100% honest with this. Those that stick to the plan pass the boards. If you're one that doesn't study, doesn't stick to the plan, you're going to be one of those people that fails and not understand why you failed. Right? Maybe you're playing too much on Twitch, you know, a little too much Among Us. And then I'm going to be sus at you. Yeah, green, orange is sus. Orange is always sus. So that's kind of the thought process when we go through this. So, well, that's what I'm getting to right now. So don't totally freak out. The optimal time to prep for an exam is anywhere from 4 to 8 weeks before the exam. Ideally, I like 8 to 12 weeks, so about 2 to 3 months. So I'm going to start planning this. Once we get these books to you, we're going to start scheduling so that you guys take one of the first exams so I can start putting together a calendar for you. That exam is actually supposed to be part of your PTA204 class, which Dr. O'Neill will talk to you about then. I'll let her kind of talk to you through that. But, you know, once you have the books, you can feel free to take one of the exams right away if you want. Do not cry after taking the exam. Don't cry, please. No woman, no cry. With the score builders, let me bring up my whiteboard here real quick. So with score builders, right? So when we talk score builders, let me maximize this window. With score builders, a go score in score builders is about 85%. And when I say a go score, that means if you get an 85%, I am really confident you will pass your boards. When you take your boards when you take your first score builders for the very first time, I am expecting most of you to fall between 52 and 65%. Now everyone's starting to freak out. But here's the deal. If you automatically are at 85%, you might get a little complacent. If you're down here in the 52 to 65%, you kind of get your butt in gear, don't you? I mean, I've seen students, there are 3 practice exams in here. Oh, 3. Plus, there are custom exams you can create. So you can go into their site and then say, okay, I want to take just a neuromuscular exam. You can set up to just take a neuromuscular exam. So there are, I want to say 800 or 1,000 total questions that are in their exam bank. I forget off the top of my head. I know they told me it, but I don't remember right off the top of my head. There are at least 600 because you have 3 practice exams, right? But there are more. Now, what happens if you come in at a 45%? Not the end of the world yet. I've had people that got a 45% and 6 weeks later passed the boards. What do you think the difference was for those people? Motivation. How much did they study? I had a student, this was one of the previous cohorts, and this is like to this day is still one of my stories I tell about this. He's a bodybuilder. And one of the body composition fitness guys. He came in and he got a 45% on his first test and was just absolutely livid with me. I'm never going to pass. How the am I going to pass? What the? I just suck. I'm just go work at Walmart. Go work at the gym. I'm never going to do this. He took his second exam. He got a 50%. Oh, you see what I mean, Mr. McKeever? I'm just not going to be able to do this. So I was like, whoa, wait a minute. How are you studying? Well, I spend about an hour a night reading the book. Oh, well, what if you were getting ready for one of your competitions? How long do you practice for your competitions? Or how long do you, well, I spend 4 to 6 hours in the gym getting ready for my competitions. And all of a sudden the light went on in his head. And he's like, oh, so you're saying I should treat this like one of my competitions. Yeah, and so for the next 3 weeks, because he had 3 weeks to exam, for the next 3 weeks, he spent 4 to 5 hours a day studying and prepping and doing practice exams and doing stuff like that. And he ended up with almost a 700 on his boards because he took it seriously. I've also got some people right now that are out there that, you know, here's the deal, guys. I don't know how much you guys know this, but I follow you guys a lot. I pay attention to what's going on in the real world. I keep an eye on some of you guys that I'm worried about, especially once you guys are out in the real world when you're out of my class. And this one student I know is spending a lot of time playing video games and not understanding why he's not passing his boards, because he's trying to start up to become a young new streamer on Twitch. And he's streaming for 6 to 7 hours on Twitch a day. Right? That's a day job, right? If you want to get good at passing your boards, you've got to put those kind of things aside for a little bit. They'll be there for you. Twitch isn't going away. Right? You need to focus on this as this will be your day job until you pass the boards. Right? Does that mean you can't work? No. I've got a couple of students that are working as techs because they feel that it helps them kind of sync what they're studying with what they're doing. I've got 2 right now that I know that are working about 4 to 8 hours a week, because that way they still are close to physical therapy while they're still studying. I approve that. Great. What we should see is if you take your first exam and you're at 52%, then when you take your second exam, you're at 63%, and then maybe 77%. That's kind of what I want to see, because what does that show you? Yeah, progression. Right? So that's what I want to see. I want to see you steadily get better. I had also talked to you guys briefly about another book by Therapy Ed. That was the one I said was about, I said it was, I think it's 67.50. I was waiting for you guys to see if you guys are interested in getting it. That is not part of your tuition. That is something that's out of your own pocket. You don't have to get it. Therapy Ed is harder. So on Therapy Ed, I want to see you get about a 65% or better. And usually when I see somebody take the Therapy Ed for the first time, they're usually in the 45 to 50% range. And usually that's the one that kills people the most. Because you get a 45%, that just is absolutely demoralizing, right? Would you feel that way? Would you feel demoralized? Yeah, you would, right? Right? Exactly. But you have to remember something here real quick. For your national boards, the NPTE, well, remember this for your NPTE. How many questions are graded on the NPTE? How many questions? Do you remember? Yeah. So there are 200 total. Out of that 200 total, only 150 are graded. There are 50 test questions. For the last board, so for the January board, a passing score was on average 96 out of 150. So 96 out of 150 is a 64%. So that literally means you can get 54 questions wrong and still pass. Now, does that mean every person needed a 96 to pass the boards? No. Some people only need 85 because they got all level 3 difficult questions. I'm going to talk about that in a second. Some people needed 102 because they got all easy questions. It depends upon the mix of questions you get, and that mix is randomized. So when you look at this, that's why I set these goals here, because here's the deal. If you hit an 85%, can you get a 64? I have to look that up. I'm not sure off the top of my head. I can check that in a bit. I have the stats. They're just on a different folder. I've got to look it up. I'm off the top of my head. I don't remember. Yeah, I can get it for you. Then I just don't remember off the top of my head exactly this moment. I know I'm stressed out about it because so for you guys, just to let you know, and this is not putting, well, this is to put a little bit of pressure on you guys. Understand this is part of my job responsibility. Part of my job responsibility is test prep. So that means if you guys don't pass and you don't do well, who is inherently responsible for that? Me. Yes. Right? And so this is why I take this personally. This is why when I give people suggestions and they don't follow them, it kind of bothers me because this directly affects me. Right? It directly affects the program. If we don't have a right pass rate, guess what they can do to our program? Shut it down. Right? So this is why I get a little worried when people don't take this seriously, because literally my job is on the line with this. I don't want to put that pressure on you, but I also want to put that pressure on you guys a little bit. So that means when I give you guys feedback and I say, maybe not now, maybe wait till the next test, it's not because I'm being mean. I am literally speaking from experience saying, you aren't ready. If I say you're ready and you still fail, that happens. You know, you could have had a bad day. We had one girl once that got in a car accident right outside of the national boards, or about 3 blocks away from the national boards, that her car was totaled. She ended up walking down from the 3 blocks away to go take her boards, and she failed. Well, I mean, could you have predicted that? I could have. I would have just eaten the reschedule fee and rescheduled, because that's too traumatic to go take a test on, right? I've had people that their parents have died before going for the boards. Reschedule, right? Life happens. So don't be thinking that just because you reschedule, you're not a bad person. You're just an adult. Can it affect financially? Sure. But it can also affect you financially if you fail, right? If you fail twice, that's $1,000 you just lit on fire. And I don't know about you guys, but I don't like lighting $1,000 on fire. Right? I'm pretty confident if I said I'm going to light $1,000 on fire, some of you would be like, no, just give it to me. The board can be taken 5 times. So this is the way the board works. That's what I was going to get into right now. So the board itself, like I said, I want to put the numbers back up here. Let's go with blue, because blue is pleasant and calming. So the NPTE, or as I call it, the NPTAE is what I call it, because your physical therapist assistant exam, is a 150 question test that you need to get 600 points in to pass. That's an S, I promise. You can take the exam 5 times. At the 5th time, there is and I don't ever want anyone to worry about this or think about this. At the 5th time, the board, the national, or the board of the state can possibly allow you to take it a 6th time, but I've never seen them do that. So this is literally 5 strikes and you're out type deal. So I don't want anyone to get there. I want everyone to be a 1 time and you're done. That's kind of where I want everybody. Because if we start thinking about this, you're already setting yourself up for failure. I mean, it's nice to know that if I fail at once, I still have the ability. And I'll be honest, a lot of good people fail the boards. Just happens. You know, especially I've had a lot of people, good people, fail the boards by 1 point. So how does this point system work, right? So the point system goes from 400 to 800. 800 is a what score? Does anyone know what 800 is? 800 is perfect. I think we have 1 currently out of all the students that have gone through the PIMA program. If you score, it's your CI? Yeah. If you score 700 to 800, you go on the wall of fame. You get a little plaque that I put you up on the wall of fame down by the computers. Please score that. I miss putting names up there. I like that. That's one of my favorite. Honestly, it's one of my favorite things is when I get to put names up there, because I have to go talk to Mr. Gentile and get the plaque part ordered, and then they lose it and I have to order it again. And it's all kinds of fun. But you need at least a 600. So how does that work? Well, all of your questions are ranked on a level 1 through 3 scale. Okay. Now there's a breakout for each of these, like one is called inductive, one's deductive, blah, blah, blah. But the way I like to think of these in my brain is a level 1 is a recall question. What would be an example of a recall question that you could think of that might be on your boards? Just a general recall, anything from the practicums. Yeah. Where is the biceps brachii in relation to the humerus? Is it on the anterior surface or the posterior surface? That would be a general recall question. Hopefully you'd get that one right? It goes on the posterior surface. That's where it's at, right? No? Okay, fine. A level 2 I call synthesis questions. A synthesis question is now going to take a general recall question and put some type of a patient to it. So let's talk about biceps. So I talked about where the biceps was. A synthesis question may say, your patient has a spastic bicep and you are now attempting to stretch the biceps for them to relieve the spasticity. The proper position to put the biceps on maximum stretch is, and then you have to go down and figure it out. So that's one where you're sitting there kind of bicep back here, right? That's starting to get into that synthesis question. Or maybe talking about patient that's got Parkinson's, which type of medications they may be on versus L-DOPA versus Sinemet. That would be a synthesis question. And then we get to the L3s. I call them my application questions. So now, that is application, I promise. I can't write with my mouse. So now with an application question, you're going to be presented a patient that has some sort of a disorder, some sort of a problem, and your objective is to pick the best and safest treatment. And the key thing I just said there is safest. Your safest is always going to be the right answer unless the question asks, which is the least safe method of treatment. You should always be thinking safety, gait belt, good, strong assisted devices like parallel bars or walkers, Hoyer lift transfers for patients that are max assists. Safest is always going to be the right answer, unless, again, the question asks for which is the least safe. And if it's least safe, you should be able to figure that one out. Oh, look, it's a cane on a glass floor. That would probably be least safe. So when we're going through these questions, these are going to be ranked points-wise. We do not know what the points are. They don't tell us that. It's not like this is worth 4, this is worth 8, and this is worth 12. They don't tell us that. You're going to get a mix of all of those questions. Ideally, the board should be about 33, 33, 33. Meaning 33% level 1, 33% level 2, 33% level 3. That's not always the case. You may get 40% of level 3s and only 10% of level 2s, and then 40% of level 4s or something like, or level 1s. That happens. It blends all those questions together, and then once those points are added up, that will get you to the 600. You also have those 50 questions that don't count. You do not know which questions those are. But here's the deal. If you're going to take your boards in April and there are questions about COVID, it's likely they don't count. Likely. Because those are new questions. Right? That's a new disease. Farm questions, especially really, really in-depth farm questions, probably aren't going to count, but I can't promise you that. Excuse me. So once we go through and you take all your questions, it gives you your score. You get a 600 or better. Congrats, you passed. No one will ever ask you what you got. No one. No one cares. As long as you're licensed, that's all they care. No one wants to know if you got a 600 or a 750 or an 800. You know, I brag because I got a 793 only because I'm a braggart. And I missed that one question. That still kills me to this day. So what happens if you get below a 600? Well, you fail. That does not mean you are a failure. It just means you failed. So if you get between a 500 and a 599, it's just a failure. I don't know what to tell you. What we can do afterwards, we can look at what your weak areas are. We can regroup and we can work together. I'm working with a student right now who I'm working with her 4 hours a week, keeping her focused. It's just because she failed and she didn't do so well. So now we're focusing, we're trying to keep her going along lines. I will tell you this is different than any other school you're going to go to. When I graduated from Penn State and I got my degree in physical therapist assistant, do you know how much they helped me with my boards? Yeah. They're like, congratulations, you have a degree, you're an adult, go figure it out. So I will be here until you pass your boards, unless they fire me, which I hope doesn't ever happen. I will be here till you pass your boards, whether it's first time, fifth time, whatever it is, I will be here. If you need me to study with you for 2 hours a night, now that might be a little rough for me, but if you need me to study with you an hour a day or something like that to help you get studied, we will do that. I will hold review sessions up until your boards where we will talk about stuff. I usually hold them virtually because that way, if you guys are on clinicals and we want to do one over lunch or something like that, we can do it and you can jump on. I also record them just like I record everything else. If you go to my YouTube page right now, there's a section that's listed as PTA209. PTA209, yeah, I have your, well, again, it's vested self-interest, Erica. I'm just going to say it. It's a vested self-interest. If you do well and you pass the boards, I keep my job. Just saying, I keep my job if you guys pass. If you go to my YouTube channel, there's a section called PTA 209. PTA 209 is that 2-week class you guys have at the end. That's called PTA seminar. That's where I put all of my previous test prep sessions. Those are all up there for you to review. I'll talk about that in a second, Adrian. That's actually a great question because I'm going to talk about the paperwork next. So I'll hold that for 2 seconds. Those are up there for you to review. That's where I'll put any review session we do. What I usually do when we're prepping is I'll say, hey, we're going to hold a review session on Friday at 12 Pacific. If you can be there, great. If you can't, send me the topics you'd like me to cover. And what I'll do is I start the session off with a whiteboard just like this. And I'll say, this is what people want to cover. And I'll write. I'll come up here. I'll be like, okay, so people want me to cover pediatric reflexes. People want me to cover synergy patterns. And we'll just go down the list, crossing them off as we work through the review session. And if somebody like Adrian's like, oh, hey, I forgot, I want to know about muscle relaxers, we'll add it to the board and we'll cover it. I will hold as many of those as we need in order for you to get past. Back to this 500 to 599. If you get that, you're going to retest. Is the board timed? That's a great question. The board is timed. You have 4 hours to do it. 4 hours for 200 questions. You can do that. So the sections aren't timed. So it's not like you have 50 minutes for section 1, 50 minutes for section 2. You have a block of 4 hours. In between section 2 and section 3, because there are 4 total sections, in between section 2 and section 3, there is a scheduled 15-minute break that doesn't count towards your 4 hours. So you can get up, go to the bathroom, get a drink, that type of a thing. So your 4 hours is just across all 4 sections. If you take an hour for section 1 and 20 minutes for section 2, that's what you take. Most people finish within 3 hours. But if it takes you all 4 hours, don't freak out. Some people, it just takes longer. I finished mine. I remember because I finished my total time period and I sat at the end, I'm like, was this it? I finished mine in 1 hour and 57 minutes. And I sat there going, oh God, I screwed this up. But it was just that I just got through the questions and it was done. It is, right? So each section, each 50 question section, because you have 4 sections, 200 total questions, 50 per question. You have a chance to review your 50 questions at the end of each section. So maybe you marked a couple of them for review. You can go back and review in that 50-point section. Once you submit that 50-point section, it's gone. Never can come back to it. Adios, peace out, home slice. You're on to the next 50-point section or 50 question section. Same thing, you get to the end of that, you can review that section. Once it's shot off, it's gone, you can't come back to it. So, that means if you get to section 4 and you're like, oh my God, that's what question 2 was. It's already gone. It's adios. You can't, there's no going back to it. So that's why you want to make sure you review what you need to review at each section. If, for God forbid reason, you score below a 500, this is the problem. Because if you score below a 500, probably you and me or Dr. O'Neill and you are going to have to go before the board and explain why you scored that. And basically it's the mother, may I take another test? Most of the times it's just a formality. You go do it. They're happy with it. They ask you what you're doing to study better. They'll ask us what we're doing to prepare you, and it's over. I've only ever had to do this once. But the reason for that is if you get less than a 500, you're doing worse than guessing. On average, psychometricians that have taken this test that have guessed through it score about a 500. And you may be second guessing yourself. Does that make sense as far as the actual layout of the boards, at least? We'll get more into it later down the line. Let's cover your licensing. And again, I'm going to beat this into you by the time you get to your test. Okay, so don't total freak out now. Excuse me. So let's get the licensing. This is what I asked you about your packets. So I know Nevada, and I know California, and I know Arizona. I'm not too familiar with Utah. I know a little bit about Texas, and I know a little bit about Idaho now, just because I've had students in all those areas. Oh, I also had New Mexico, but I didn't really help with that person, so I don't know much about that. For whatever you're going to take it, if you decide that you're going to be moving out of state, I don't know much about Washington either, but we can find out together. That's my offer. We can figure it out together. If you decide you're going to go out of state to work, that's your plan. Like, I know, I'm drawing a blank. Somebody's going to Tennessee, and I can't remember who it was right off the top of my head. Why am I drawing a blank? Oh yeah, Erica, sorry. I knew it was somebody, but my brain was just not working. Okay, so Anthony's staying in Arizona. So there's an option here. You can do your tests 2 different ways. You can register in Nevada, take your test in Nevada, get licensed in Nevada, and transfer your license to the other state. That's a possibility. The other thing we can do is when we get your packets together for licensing, we can just prep your packets for whatever state you're in. So if Anthony's going to Arizona, then we'll just get the Arizona packet from the Arizona board. We'll work on just prepping for him for getting licensed in Arizona, right? My school was in Pennsylvania. But unfortunately, when I looked to take for my test, there were no sites in Pennsylvania, and it was a pain in the butt. And I knew I was going to work in Maryland anyway, so I registered my license initially in Maryland. Took my boards in Maryland, got my license in Maryland, then just transferred it to all the Keystone states or the tri-state area. You can do that. Like Erica, who said she's going to Tennessee, she theoretically could register here in Nevada, take the test here in Nevada, and then as soon as she's licensed, transfer it immediately to Tennessee. Or we could register her in Tennessee. She can take her test in Tennessee. Well, actually, she doesn't even have to take her test in Tennessee. She can register in Tennessee, get approved by the Tennessee board to take the test, and take your test anywhere. Like, even if you're here in Nevada and you register in Nevada, you can go take your boards in California. The registration is just going to be wherever your license first shows up. Does that make sense? And whatever board approves you for it. All boards have a little bit different procedure. In Nevada, there's an application, not an app, like put an application. And then there's a jurisprudence test. What does jurisprudence mean? Anyone know what jurisprudence? Local laws, yeah. The jurisprudence test in Nevada right now is a joke. It's a 10-question written test that you're not allowed to use the book for, that you do on your own. In states like California and Arizona, they also have a jury test. They're a little bit more difficult, especially California. California's jurisprudence test is a beast. I think it's 50 questions. But here's the deal. Even if you get registered here in Nevada and transfer your license to California, you will have to take the California jurisprudence exam. They give you, I think, 6 months to take it, but you have to take it no matter what. I'm going to be openly admit I failed my jurisprudence exam in California the first time I took it. I wasn't prepped. And a lot of it is just going through the Board of California, the Board of Nevada, the Board of Arizona's website and reading the rules and knowing what the normal ratios are, knowing what you can do as PTA and what you can't do as PTA. I will help you through that. Yeah, pretty much. So Jesse asked if you're licensed here and then moved to, do you take that exam no matter how long you've been licensed? Yeah. I've been licensed since 2007 and I had to take the California board. And then some states have a retake, not all of them. Like Nevada here, once you've taken the jurisprudence test, you're done. You don't ever have to retake it. California, I think it's every 5 years you have to take the jurisprudence exam. Don't quote me on that. I forget off the top of my head. It's probably why I failed the jurisprudence exam. Come on, that was funny. That was kind of funny. Idaho was a lot easier. Utah, I'm not as familiar with. Texas was super easy to get licensed in. Out of all of them that I think that were the hardest that I've had to get licensed is California. That's probably the roughest. The Arizona jurisprudence exam's a little bit of a pain in the butt. So Anthony, sorry. But it's not that bad. The hardest part about the Arizona jurisprudence exam is finding where the local laws are on their website, because their website is the most disorganized. Yeah. It's trash. Exactly. God, it's horrible. Like Nevada's at least is better now that everything's organized, little drop down links. You need to find the stuff, you can find it. Arizona, it took me like 4 days to figure out where the laws were. I'm like clicking around. Come on, you type laws in the search and it bring up like laws for Oklahoma or something. It was really frustrating. But I've got Arizona down a little bit, Anthony, so we can probably help you with that. So don't totally worry. Erica, I've done a Tennessee license already, so we can do that. And actually, I have a contact for you that probably can help you as well from a previous cohort that's licensed in Tennessee as well. So she can maybe give you some pointers on what she expected transferring it. So I sent her a text message, Ashley, asked if I can give her your email or give you, oh, how about this? Can I give her your email address? Your PIMA. Okay, that makes it easier. I'll just tell her if she can email you, talk to you through it. She just got licensed there 2 or 3 cohorts ago. So she's fairly fresh. Same reason, by the way, for you. But so that's basically the licensing itself. We have to get your packets together. And I know I'm running pretty close to burning you guys out here. The packet is by state. Let me bring up the the Nevada one just for an example here real quick. This out. Nevada board. Licensure. Give me 1 second here. I'm just bringing it up. Where's that at? Right there. Okay. So this was what I asked you if you guys had started yet, but we'll get there. You haven't started. It's okay. It's not the end of the world yet. So this is kind of looking at this as an example. This is the Nevada physical therapy application, right? So the good news is most of the application have all this stuff, what you need to do. We're going to put this up for you to start working on. The only thing I highly recommend you not doing yet is up here with fingerprinting. Wait to do fingerprinting until we tell you to do fingerprinting. And Anthony, fingerprinting is a little different in Arizona, so we'll talk about that. Erica, same thing. Fingerprinting is really different in Tennessee. Go figure. So you'll go down through this application, and it tells you what you need to do. You need to provide this. You need to provide that. You need to provide this. If you are military or spouse of military, you do get a discount on your license application. I don't know what it is off the top of my head, so don't quote me on that yet. We can look at that. But you're just going to go down through all of this and fill out the application. So we're going to get down here to the actual application, right? We're going to go through and fill all of this out. Fill out your education, going to fill out your current employer, physical therapy experience. This is going to be your clinical rotations. Oh, and the test itself, maybe you might, I don't know. I've got to find out. So you're going to go all the way down through this. This is those kind of legal questions that everything has. If you are subject to an order of child support, it doesn't mean the end of the world for you. They just want to know if you are. Because guess what? If you don't pay your child support, guess what they can do? Suspend your license. So the board does need to know that. Just if you're a good person or not. Here's kind of general information about you. So these are the normal fees. Application for a PTA is $225. That goes to the state of Nevada. And again, like I said, there are discounts. I'll show those. I won't show those right now, but and then the examination, I think they've got this wrong because I want to say it's $485 now, and I've got to get them to fix it. Part of this here is a legal affidavit. Do not fill this out until you are in front of a what? Who are those people that put their seal on stuff? Notary. Yeah. I don't know. I know in previous classes, we've had students that were notary publics or family members that are notary publics. If any of you are, contact me. Maybe we can work something out for the other students. If not, UPS stores do notaries. Your banks usually have a notary, stuff like that, but you will have to have this notarized. And then this is kind of license verification. This is the funny part down here. If we keep going, you guys can become, oh, cool. You can become a graduate status PTA. I wanted to cover this for some of you people that are worried about money. Let's say you are worried about money. You've got a job offer once you're done with your clinical rotations, but you don't feel you're ready for your boards. You need another couple months. You can apply for graduate status. What graduate status is means you can work as a PTA. I want to say it's 6 months. I don't know off the top of my head. I don't know if it says it here. Yeah, it doesn't say on here. I think it's 6 months. It's in the bylaws. And you can work for that period as a PTA as long as you have a direct supervising PT. and they sign off on you. So you'd go to your job, they'd sign this form for you, you'd send it into the board, and you are considered a graduate status PTA. That means you can work fully, completely as a PTA. It's just you haven't taken your boards yet. That can be useful for some of you that, you know, like, I want some extra time to study, but I also need to make a little bit of money. It can be rough. These are usually ones that get job offers right from your clinical affiliation. It's not like jobs really advertised will make you, you know, you see a job posting. Well, I'm kind of looking for a graduate status PTA. Can you give me a graduate status? Doesn't usually work that way. Usually these are people that are going through, well, it depends. So when I offered graduate status to my PTAs, usually I usually offered $4 less an hour. So, you know, if my base rate was 26, the graduate status would get 22. But I also did pay a lot differently than a lot of other people do it, because I paid for performance. The longer you stayed with me, the more you made, which I always thought was logical, because most PTAs last about 6 months at a job and then job hop. So I would incentivize you and say, if you stayed with me 6 months, you got a raise. You stay with me 12 months, you got a raise. Stay with me 18 months, you got a raise. It always worked for me. And I always had people that stayed forever. But it depends. I know some of the clinics in town that do the graduate status where people pay full PTA rates. So it just really depends. I know that I can't quote specific clinics because I don't want to call them out on it, but I know that some of them are clinical affiliations have paid full rates for them. And that's just a negotiation you do with whoever's going to be your supervising PTA, right? You can say, hey, you know, and if you really wanted to, that could be a bargaining chip for you. You could say, hey, look, I'm willing, you know, they made a job offer for you as a PTA. Say, hey, I'm willing to work for $2 less an hour if I can work as a graduate status while I get ready for the exam. To me, I would rather do that to you as a supervising therapist. I'm not a supervising therapist, but you know what I mean, as a supervising therapist. That way I know you actually pass the exam and I don't run the risk of losing you. Great question. Hold that question until I'm done with the things, just then we'll finish off with that question. So then if you keep going down here on the site, look, there is the jurisprudence exam module right on the application, almost like you could look at it and prepare for it. But you're not allowed to use your book when you do it. So don't use your book. Oh, it's now 20 questions. They updated it. It was only 10 before. So you have to include that with your packet. So all of that has to be in a little packet for you. What I recommend you doing, once we start doing this, and I can post a link to the packet so you can at least take a look at it. What I recommend you guys doing is getting a manila envelope and start putting your stuff that you need for licensing in it. I even put my money in it that I needed for paying for my boards, paying for my stuff like that, just so I didn't spend it. And then I had that ready so that when I was ready to send my application in, I just sent that manila envelope straight into the boards and it was all done. You have to make sure that if there's an order on their applications, whether it's here in Nevada, which is really strict about this, or Arizona is another one that's pretty strict about it. If it says it goes in application, fingerprinting, jurisprudence, blah, 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 you have to send it in that order. Or like me, when I was applying here in Nevada, I sent it to them out of order. They sent it back to me and told me to put it in order and send it back. You know how frustrating that was? It was really annoying. Like it says right on the packet, yep, this is the order the stuff goes in. Put the stuff in that order. Don't mess with it. Right? They can be a little petty that way. All right, so we'll talk more about that. I'm going to stop my recording because that way we're done with this part of it. So let me just